Very good evening to all of you in India, and good morning to people in US and Canada, and good afternoon to people in UK, and good night in people in Singapore. Let me have the pleasure of inviting you all for this IIRSI webinar on OCOP, which is a very interesting webinar on one case, one pearl. We have an extremely good faculty here of about 10 speakers, and we have got a fantastic team of panelists as well, starting with the president of the AIIRSI. I'll be introducing the panelists very soon. I'll also tell you the pattern of this webinar in a couple of minutes. Before we start off this webinar, I would like to thank Entoad Pharmaceuticals for their willingness to sponsor this webinar. They have always been a great support for the entire ophthalmology in this part of the world is concerned. And it's also a pleasure to have them on board here. And today is the 43rd Foundation Day of Entoad Pharmaceuticals, which is one of the top ranked pharmaceuticals in the entire world today. And if you go through the history of the Entoad Pharmaceuticals, very inspiring and motivating story, starting from Nikhil Masurkar's grandfather and great-grandmother, who started the entire work with the herbal medicines, and subsequently his great-grandfather, Mr. G.V. Masurkar, started the Entoad Pharmaceuticals. He left UK and came to India to start this fantastic company. And then subsequently Kishore and also Nikhil have taken over the legacy and probably kept the flag very high as far as Entoad Pharmaceuticals is concerned. As far as India is concerned, it's an international name to reckon with, and we're very proud to be associated with the Entoad Pharmaceuticals as well. Now, before we go on to the OCOP webinar, I would like to request Mr. Rahul of Entoad Pharmaceuticals to show an introduction video for about 57 seconds about the Entoad Pharmaceuticals. Thank you very much, Rahul, Raman, and the entire team of the Entoad International for the wonderful video. It's a very inspiring story. I only wish that all the ophthalmologists and all the delegates have a glimpse of this wonderful, inspiring story of Entoad Pharmaceuticals and Entoad International, which has become the pioneer as far as the pharmaceutical industry is concerned. And we know that they are also a very big supporter of the CME programs. And this year, they have been a very big supporter of the webinars. They entered online meetings, and today the IIRSI OCOP program is a perfect reflection of the fact. Friends, I'm going to share my screen now and go on to the main program. And are you able to see my screen?
Yes.
Yes, sir. This is the IIRSI, as I told you, the Indian Intraocular Lens and Refractive Society of India. I'm thankful to Professor Amar Agarwal for having given this wonderful opportunity to me for conducting this webinar. And this is a one case, one pearl webinar, which is going to be for the next 2 hours. And we have a wonderful team of panelists, as I told you earlier. Professor Maipal Sachdev, who is the chairman of the Center for Sight. He is a household name in not only in India, but also the world over. He is also currently the president of the All India Ophthalmological Society, and how he is literally leading the AOS to greater heights, even during these challenging times, is really a fantastic task by Dr. Maipal. Dr. Maipal is held up in another webinar. He will be joining us very shortly. We also have with us Dr. Professor Namrata Sharma, and who's also the secretary of the All India Ophthalmological Society. Is also the gold standard as far as the cornea and cataract surgery and refractive surgery is concerned. She's a professor in the RP Center, AIMS. We've got several publications and several innovative work as well. We also have with us the panelists, Dr. Gaurav Luthra, Chairman, Academics and Research, IIRSI, Director of Drishti Group of Eye Hospitals, Dehradun. And Gaurav Luthra is a very dynamic cataract and refractive surgeon. He's got a beautiful hospital in Dehradun, a very, very excellent speaker as well. And also with us, the Kamal Kapoor, I call him the Delhi Hurricane, the medical director and co-founder of Sharpside Group of Eye Hospitals. They've got more than 20-25 centers in the Delhi and NCR, and also as well as abroad. And he's also a fantastic cataract and refractive surgeon. So with these few words, the panelists, I will tell you the pattern of the webinar. I am Dr. Mohan Rajan. I'm the moderator for this webinar. Along with me is Dr. Ravi Shankar, who is going to be co-moderator for this webinar as well. The pattern of this webinar is that we'll be having 10 speakers. The speaker number one is, as the speakers come in, I will introduce each of these speakers. Each of the speakers will give a video or a challenging case for about 3 to 4 minutes. After that, I will shoot some questions to the speakers, and then I will take it to the panelists. And then I will ask all the speakers, other speakers also to comment. And then we'll go on to the audience questions. The audience link is there with Kamal Kapoor, as well as with Dr. Ravi Shankar, as well as Dr. Nishant as well. So this is the pattern of the webinar. We hope to finish in about 2.5 hours max. We don't want to drag it beyond that as well. So let me introduce the first speaker now. The first speaker is none other than Professor Dr. Ronald Hu. He is a, he's a well-known name, not only in Singapore, but also in the Asia-Pacific region, but also in the world as well. He's a consultant in SNEC, Singapore National Eye Center, which is the apex center as far as the Singapore and South Asia is concerned. Director of the Eye and Retina Surgeons Associates. He is the past president of APCRS, and I would say that it's been a golden era in the APCRS when Ronald Hu was the president. And he's also the professor in NUS Graduate Medical School as well. Ronald Hu is a very, very prominent cataract surgeon, and he's a very innovative, powerful speaker, and his videos have won Best Videos Award in the ACRS and ECRS as well. And he's going to talk to us on a very, very important topic today. I'll stop sharing the screen now and over to Ron Hu for this.
Thank you very much, Mohan. Let me just bring my screen up if I may. Well, I'd like to thank the IIRSI, Mohan, and Amar for really inviting me to join you guys tonight. Can you see my video now? Can you see my screen?
Yes, sir.
Great. Okay, so thank you. So one case, one pearl. I'm going to share one pearl, but use several cases to demonstrate this. And my title is really the en-bloc maneuver for softish cataracts with hydrodelineation. All of you have heard me speak on really the neither here nor there cataract. We know that hard cataracts are, in India, you guys are all experts in doing hard cataracts.
Can you be a little louder, sir, Ron?
Sure.
Yeah.
The soft cataracts, you really just aspirate, but neither here nor there. I like two techniques. One is the pre-chop for the 50 to 60-year-old, and the en-bloc technique, which I'm talking about now, for the 30 to 50-year-old. So the heart of the en-bloc removal of the soft nucleus is hydrodelineation with the golden ring that frees the nucleus for easy removal with vacuum. Let's look at this. Hydrodissection is done first, and then the hydrodelineation step, from which you can see the gold ring appearing very, very clearly. After that, clear the cortex in front of the nucleus, go to memory 2, impale the nucleus with your phaco tip, and lollipop the nucleus onto the tip of your phaco, and the operation's over, right? I mean, you've taken out this small, soft nucleus, and now the epinucleus is removed, which is why you also need to hydrodissect and not just do hydrodelamination. Let's look at a second case of this same technique. Again, here we're doing hydrodissection and hydrodelineation, really almost in one movement. And you can see that this one, there is a much larger golden ring. Again, after clearing away the pre-nuclear cortex, you go into memory 2 and impale the nucleus. But you can see here, it's a little bit more difficult. Why? Because this nucleus is bigger and it's a softish nucleus. But because your hydrodelamination, is good and has freed the nucleus, this nucleus then comes really into the port of the phacotip very, very easily. And again, this operation now looks slick instead of you trying to chop a very soft nucleus. Let's look at another example of this. Hydrodissection first, nucleus is moved. Hydrodelineation now with the golden ring showing very, very clearly. And now I like to use the live OCT to help us understand what hydrodelineation actually is. And if you look at the two images on the right, you can see that layer of fluid at the back. In both of these really angles at which the cut is taken. And when you've lollipopped and taken away the nucleus, you see how that beautiful empty space left by the nucleus with the epinuclear shell is left behind. Now let's just look at one other case. Now in this case, you can see that this nucleus is much smaller, and I'm able to free at the back. You see the fluid level at the back, and then you see the fluid level at the front. So you know this nucleus is now totally free for you to lollipop onto your phacotip to make this soft nucleus much easier to handle. Okay, and here's just a still image of what a hydrodelaminated nucleus will look like and what it looks like after it's been removed. So my last video clip here is one more hydrodelamination, and you can again see this small nucleus being delaminated. In this case, there were actually two golden rings. And if you look carefully, you will see that there's a small nucleus here, and there's actually a larger hydrodelamination ring outside there. Now, if your hydrodelamination golden ring is very large, sometimes it's hard to pull the whole nucleus out. And what I do is revert to my favorite pre-chop technique that Akahoshi taught us. You go in and just split the nucleus into two. And then, of course, it's very easy to pull each heminucleus out of the eye. So just to sum up, the en-bloc technique for these very soft cataracts, hydrodelaminate, you must see the golden ring, also hydrodissect so that you can get the epinucleus, clear the cortex, impale and lollipop the nucleus, and if the nucleus is very large, won't come, you can pre-chop or chop it as well. Remember, we don't only get the dense, hard, white, black nuclei, we get the soft ones in these days of refractive cataract surgery, and you really need to deal with these simply. Thank you very much. That's it.
Beautiful. Fantastic. I think, I think it is a perfect opener, Ron. I think because everybody knows that hard cataracts are tough, but many people do not know that soft cataracts can be more difficult than the hard cataracts or even the small pupils. Okay. And I think you have given the message very correctly. Before we go on to the panelists and also the audience questions and other speakers, I want to ask you one thing, because you got in the term because you got a best video award in soft cataracts in ACRS a couple of years back. I know very well. But you got the term called NHNT cataracts. I remember that very well.
Neither here nor there. Yeah.
Neither here nor there. Okay. Whatever you showed that, I think your rexis was a little larger than the normal. That's what you aim for in softer cataracts?
I don't really, Mohan, I try to keep a standard size for the IOL because I think it should be dictated by the IOL cover that we want with the rexis rather than the density of the nucleus.
What is the size of the rexis? 5.5 or 5?
My rexis is usually about 5 to 5.5, yeah.
5 to 5.5 because the cases, the first two cases you showed was really soft, and either way, if you do a hydrodelineation, it's going to lollipop up. Okay, but the NHNT cataracts are the very tough cataracts, as you know very well, and you have described that very nicely. These are cataracts with never chop, never crack, never suck as well, and very difficult to hold also. So what are your take-home messages for NHNT cataracts, which are neither here nor there, in between?
Essentially, it's recognizing them, Mohan. I think it's if you go in and you just do and don't think about it, just do a stop and chop or direct chop, as you noted, you can't grip them. So to me, the most important thing is making a note in your clinic that this is a neither here nor there nucleus, and then either do this good hydrodelamination with en bloc, or you do a pre-chop technique, because stop and chop is the wrong technique for neither here nor there cataracts.
Or can we make a very narrow trench all the way down and try to do what is called the stop and chop?
Well, it depends on which end of the soft spectrum it is, Mohan. You're absolutely right. And if you're say about 1 to 2 plus, yeah, of course you can. But if you're less than 1 plus the half plus nucleus, you're going to struggle cracking those, rotating those, and gripping those. So it's really recognizing in your clinic, in your notes, how dense this nucleus is.
Absolutely. I think these are the golden messages from Ron. I think he's the expert in soft cataracts. And being an expert in soft cataract is, if you're an expert in soft cataract, you will become an expert in phacoemulsification. It's the other way around. The hard cataracts, because you have got everything to hold, you can chop easily. Whereas soft cataracts, you have nothing to hold. The nucleus, you don't have any control over the nucleus. So let me go on to Gaurav and Kamal. Gaurav, what's your, how differently you would have done a handle soft cataracts? I want to know.
I enjoyed Ron's presentation. It's all his presentations are always really nice. He showed on the OCT especially that how the hydrodelineation and how you can dissect out the nucleus. I handle them, I use the lollipop technique as well for this, but I also enjoy doing the cartwheel phaco for the soft cataracts. And, that seems to work, although it can be, you have to be very careful about your settings. And then, of course, soft cataracts, you have to improvise all the way through. I mean, as he said, you have to first identify that you have a cataract, what is the kind of the cataract that you're dealing with. And you have to improvise on the table if you have a slightly different from the usual cataract and you're not going to chop them. So I think recognizing them and then improvising and knowing all the techniques is so important. Some surgeons say chop everything. I don't agree with that. You have to know all your techniques. You should know divide and conquer, stop and chop. I mean, a good phaco surgeon should be able to convert from one to the other on the fly. I think that's the message I would like to give.
Absolutely agree.
Gaurav, I think you hit the nail on the head. Before we go on to Kamal, I want to ask Ron, how do you, it's very difficult preoperatively, for me at least, to find out whether it's this side or that side. And because unless you put your phaco probe inside, you do not know many times that it can be very deceiving. So preoperatively, you have any take-home pearls to find out what side of the softness is there, whether it's on this side or that side?
I think that's just experience, Mohan. When you look into one of these, and age is the other thing. As I gave a guy 30 to 50-year-olds, this usually works quite well. But if you see a dense nucleus, then it's not so easy. Really, the denseness and the yellowness of the nucleus, I think, is an important guide. But what you say is right. So I may go in, like trying to do a pre-chop in a soft one, but if I find it's too hard, then I just don't do it, or I use a counter pre-chop technique. So you need to be able to change your thinking and your technique, as Gaurav has said on the fly, and not just be dead set and on one plan if you find that the eye is different.
So you should have a plan A, plan B, and plan C for these soft cataracts. Kamal, what's your take on that?
I think, Ron, a wonderful presentation.
Thank you.
As usual, the very crisp message, especially with the OCT running through the live stream. It's very difficult, very, very easy to identify what's happening. My only little small tip for beginners would be, make sure that you do not give a burst of hydrofluid going in, because that can sometimes suddenly make the nucleus rise up, or probably the whole cortical plate rise up. And in case you have a slightly smaller capsular rhexis, you may land up with a capsular drop. Number one. Number two, before you start this procedure, make sure that you've taken off some of the viscoelastic out. Because as you give the pressure of the fluid in, the viscoelastic can come and actually block your wound. And especially if it's a cohesive viscoelastic, sometimes it can get blocked and it can surge out. Number three, this maneuver is best avoided using a side port. Do not use a side port to do this maneuver. Use the main wound. And the most important is, as Gaurav said, it's on the fly. You cannot always have it 100 times, 100 or 100 the same step. In a soft cataract, you actually need to be thinking in your head that what's going to happen next. And if that doesn't happen, your next next rabbit from your hat should come up. So I think soft cataracts, as Dr. Mohan said, are a trick by themselves. So you need to keep modifying. So you need to be adept at all the techniques. But yes, this nuclear scoop or this the nuclear delivery technique is fantastic. And it just solves the problem in a matter of minutes. The surgery is over in a few minutes, 1 or 2 minutes.
Mohan, can I just make one last comment?
Yeah.
You know, in India, you have all these mature cataracts. And if you rupture a capsule during a dense cataract, you can say, you came late, it's your fault. But you need to know how to handle these soft cataracts. Because if you rupture the capsule, who do you blame, right? You can't tell the patient, you came too early. You know?
Yeah. No, but when you, Ron and Kamal and Gaurav, because you're doing a hydrodelineation as well, sometimes you are stuck up with a very thick epinucleus. Okay, sometimes it's really a problem in removing this epinucleus. Do you have any tricks for that?
Yeah. Can I start?
Sure.
Yes, anybody.
Yeah. Okay. See, I call this saucerization. It actually forms like a saucer. You have and it starts from the capsular rhexis and goes through all the bag. One of the big tricks I do is, at times I can just put in a list of little viscoelastic and use a special bevel cannula, just go between the capsular rhexis margin and then give a small little jet of fluid, and the whole thing will rise up. Sometimes you just come out of the wound, depress your scleral lip, let the wound shallow, and this plate will automatically separate in one area. And all you need to do is you go with a dispersive viscoelastic between this layer, inject the dispersive viscoelastic, and you can separate this layer very beautifully. I'm sure there are other techniques which Dr. Ron and Dr. Gaurav will share.
Yeah, Ron?
Well, I think it starts number one, as I've said, don't only hydrodelineate, hydrodissect as well. That's number two, basically at the end of the phaco step, you will often get a feel of whether that epinucleus is going to come or not. And if you get this rim of epinucleus, I will use the phaco tip in epinuclear mode to engage one side of it and winkle it left and right. So don't suck it up first, just get a grip on the epinucleus and I will pull it left and right and away from me. And that often will cause the epinucleus shell to come out completely. Now, if it doesn't do that, then during IA, what's very important is because the epinucleus is often held in place by the cortical bed, the bed of soft lens matter. So if you just free all the cortex around, you'll find that then the epinuclear shell will come out. So I think those three things will help you get that epinucleus every time.
Absolutely remarkable. Gaurav, you have anything?
Yeah, I think they got all the points, but what I would do beyond this, like if all these things were not working sometimes, I'll go with the infusion. Kamal already said something similar. I'll go with the infusion running from the main port, and I'll just go inside and kind of try to flush it out. Sometimes what that does is it just floats the epinuclear shell into place, and sometimes it'll actually pop out if it's soft enough. If it's not, at least it'll kind of move inside and mobilize, and then you can go in with the epinucleus removal on the phaco tip. I enjoy doing that, but I won't recommend that for the beginners because they could go horribly wrong. But if you are experienced phaco surgeon, you can just go with the tip bent to the side a little bit, try to engage the epinucleus, and it kind of, if it's free floating, it'll just you'll engage it and you'll probably be able to remove it better, and then you can finish it off with the IA. I think we all probably do the same thing. Yeah.
I think the
Mohan,
key...
I just have a comment.
Yeah. I'll come back. I'll come to you, Sri. Yeah. I'm just coming to you. Just one important thing from what Ron said was, I think it's important that you remove the epinucleus in one single sheet. Sometimes what happens is if you go and catch the tip, it may break there and you will have a piecemeal there. So and then it will make your life difficult. Maybe try to remove it as you pull it out. Probably the lateral movements probably one single sheet. Am I right, Ron?
Absolutely.
Absolutely. And we go on to these speakers. I'm sorry, one by one. George, you have anything to say? I'll come to you, Sri.
I think it's very important what Kamal said, that you use your viscoelastic in some of these cases and to raise up these pieces. So go between the capsule and the cortex or the epinucleus, and that helps to protect the capsule and also to bring that piece up. So I think remember that viscoelastic can be used for other things besides maintaining the anterior chamber. So I think Kamal's point was well taken.
Thanks a lot, George, for the nice message there. And Sri Ganesh, you would like to say something now?
Yeah, it's always a pleasure watching Ron's videos. They're absolutely the best. I just wanted to make a comment that if you have a femtosecond and you're using a femtosecond laser, then you can do the technique of visco-chop, which I demonstrated in Jaipur IIRSI. So all you have to do is just go in with your visco cannula and inject into the grooves of the nucleotomy, and the nucleus splits into 4, and you can just do a single-handed aspiration, very easy.
I have seen the technique, Sri Ganesh, is really very innovative, very interesting technique as well, but you need to have the femto for that. Okay, yeah. Sujata, you have any questions and any suggestions? Or any of the speakers?
The discussion was excellent. I think the discussion was excellent, and there are several techniques where you can do. When we started phaco, in soft cataract, we used to do something called as a chip and flip. We used to carousel the cataract and then flip it out. And then we also use a spring technique where you make a quadrant and then you spring it out. So there are so many ways. And like Gaurav said, I think you'll have to change it. As you go in and you see what is the type of softness the cataract has, you change the technique as it goes. My one technique for epinucleus removal is, I think one of you already spoke about it, is injecting either a viscoelastic or a BSS. After removing the nucleus, the epinucleus can be hydrodissected again once more, so that you loosen it and it comes out easily. And that's about it.
Any of the speakers want to say something?
Imanshu.
Imanshu, come. Yes, come.
What Sujata said, and
Imanshu, 1 minute. As Kumar doctor come in because he had some problem there. Back. Okay, fine. Imanshu, go ahead.
Yeah. See, general surgeons routinely use this they're pushing saline in between various layers to identify various layers. So what Sujata said, I have got a good presentation on this, how beautifully we can just hydrodelineate from every angle, and the epinucleus is ever so willing to come out. It stayed inside for a long period of time. And what Gaurav said, as he said so rightly, for experienced surgeons, it's a little easier to put the phaco tip and pull the epinucleus. But for a newcomer, if they just push in a little saline for a BSS from multiple angles, it'll just walk out. It's just tumbling the whole thing out. That's about all.
Yeah, I think we have said it all, and it's a beautiful presentation, fantastic opener by Ron. Ron's videos are really fantastic. And it's a great honor to have Ron in this webinar because he always takes the ophthalmic education to a different level altogether. Thanks, Ron, for being here.
Thank you, Ron.
Yeah.
Thank you.
And if you have no other questions, any questions from the audience on this, Kamal?
I'm looking there. There's still no questions on this.
On this particular thing.
No questions on this.
Okay, then we go on to the second speaker. Okay. I will quickly share the second speaker.
I have a request saying that please do continue such webinars, Dr. Mohan.
Thank you very much. The speaker number 2 is actually a guy who is more an Indian than a Canadian. He attends more Indian conferences than any other average Indian ophthalmologist, I would say. George Beko is an associate professor, McMaster University, lecturer, University of Ontario, Canada, and he is really a fantastic guy, cataract surgeon, and more importantly, he is a great human being, a great friend of mine. George Beko, there are 2 eyes of Canada in the international ophthalmology scenario. One is Dr. George Beko, the other one is Steve Urshinoff, the right eye and the left eye, I would say. Because these are the 2 people who are always there in all the international podiums, whether it's ASCRS, ESCRS, AO, or APSCRS or APAO, whatever it is, George Beko is always there for us. And he's going to talk to us on a very, very important topic. And George Beko has got tremendous publications and done a lot of work on glistenings. on the Actisoft glistenings. He's done tremendous work, remarkable work on that. I really appreciate that guy, and he's got a lot of sense of humor as well. And he's won several OPLs. And I will 1 minute. I don't know where
Thank you very much, Mohan.
Oh, 1 minute. I'm just trying to stop. Yeah, over to you, Beko.
Thank you very much, Mohan. It's always a pleasure and to be a part of this program. Okay. Is this up?
That's fine. Yeah, you're very audible. No problem at all. I request all other speakers also to raise your voice and speak. Yeah.
So I'd like to thank the Mohan and Society for inviting me. I've been a part of this society for many years, and it's always a pleasure to be on the program and to learn from my colleagues. Today, I'd like to talk about piggyback IOLs. We employ piggyback IOLs in rare situations, and sometimes these can go awry. These are my financial disclosures, and they're not relevant to what we're doing. So when we put a piggyback IOL in, we anticipate that we're going to solve a problem. But the question is, what do we do when these piggybacks start to fly? So it's an unlikely event, but we need to know what to do. So this is a case in which there was a piggyback IOL placed on top of a multifocal IOL in an individual who was a high myope. So the piggyback was used to try and compensate for the residual myopic anisometropia. And as you can see, 10 years later, the lens is dislocated. So what do we do? Well, the first thing is, we prepare for our intrascleral haptic fixation. We create our flaps, and then we manipulate the haptics into the anterior chamber and make sure that the lens is nice and stable. In this case, what I'm doing is I'm using the approach the Gabor-Shira first introduced. So placing a sclerotomy and then using the handshake technique to grasp the haptic and externalize. And again, on the other side. So we're using the IOL that the patient's had for 10 years, and this is an IOL that's provided him with emmetropia, and I don't see any reason to exchange it. Now we'll put it into the scleral tunnels, do that on both sides, and in this case, we've closed it with sutures. As you can see, you can have a nice stable situation, bag in the lens, and an anterior piggyback IOL. What happens if the piggyback IOL slips in behind the lens? So we know that we can have zonular dialysis in some of these cases, and these piggyback lenses can then go through that area of dehiscence and go into the vitreous. So in this case, we've got an in-the-bag IOL, we've got a dislocated sulcus piggyback IOL in the vitreous. And the approach, again, is very similar. We'll create our flaps as we do for the glued IOL technique, as Amar has taught us. 180 degrees apart. You can see that this patient had a PK, and that's why he ended up having the piggyback IOL. Luckily, in this case, the IOL is very anterior, so we can go in with a hook and isolate the lens and grasp it, then go in with our 23 gauge forceps on the other side. Using the handshake technique, we can externalize the haptic and do that on both sides. So the IOL is in behind the in-the-bag IOL. In this case, it's very important before you do this that if the posterior capsule is intact, that you do your YAG, because it would be very hard to do that once this is done. So again, externalize the haptics, we put them in our tunnels, and then we glue, and you have a nice stable situation in a post-PK patient. And then the most difficult one is this one, in which the patient had a piggyback IOL, and both the in-the-bag lens and the piggyback were dislocated. So, and he had a small pupil. So what we've done is we've increased the pupil using our pupil retractors, created our flaps. We're passing a 9-0 proline through our scleral area underneath both haptics, And then we will create a sclerotomy anterior to where we pass that suture so that we can pull the suture through. So again, going to the other side, we're passing the needle underneath both haptics out to the cornea. We'll cut that needle off so that the suture sitting there will reach in anterior to the haptics, and we'll tie and adjust. So tie on this side, and then we'll go back to the first side and ensure that we're nice and central. So we have both haptics caught between the suture. And then proceed with gluing. And at the end of the case, you can see that the lens is nice and central and stable. So when the piggybacks start to fly, we need to consider our options and be prepared to stabilize them. Thank you very much for your attention.
Can you stop sharing? Yeah, really fantastic videos. And the take-home message from these videos is that don't try to imitate George Baco's acrobatics. You'll be in trouble. Okay? Especially the second case. Whenever I see this case, because I've seen these videos before, whenever I see this case, my heart is in my mouth because it's right behind the lens, behind the regular IOL, and it's almost in the anterior vitreous. Okay? And you are trying to exteriorize the, externalize the haptic and glue it. Really fantastic. And I was wondering, what is the reason for the dislocation or the subluxation of these lenses? Don't you use the Rayner Sarcoflex piggyback lenses?
Well, these in these cases, all of these cases were about 5 to 10 years after the primary surgery.
Okay.
The first one, there was an array lens. The array came at powers of 5 or 6, and the patient needed almost 0. So ended up having a myopic result, and then we placed a myopic lens in the sulcus, and that corrected him. The second case was a PK.
Yeah.
And so after the PK, there was anisometropia, and we placed the lens. And the third one, I'm not sure what the situation was, because I thought there was only one lens with the pupil. And then when I opened it up, I saw that there were 2 lenses there. So, you know, but we don't, yes, we have the Rayner Sarcoflex, but that's more of a refractive lens, whereas these were situations where there was anisometropia that we were trying to deal with.
Now, these are the Acrisoft lenses, multi-piece ones?
No, they're the one was the J&J.
J&J, okay.
Yeah.
What is the overall, what is the reason for the dislocation?
Well, there's some dehiscence in the zonules, and you'll see that if there is a small area of dehiscence, the lens will turn around and sort of work its way to that area. And it wasn't recognized at the primary surgeries.
Okay. And you have any experience with the Rayner Sarcoflex lens, George?
No, I don't.
Okay.
No.
We go on to Kamal and Gaurav. Gaurav?
Yes, sir.
You are online. Okay. Gaurav?
Yeah.
Tell me what you would have done differently, and what is your experience with the piggyback lenses?
Okay, so I think, Josh did an amazing job. First of all, the piggybacks will be very few, and then getting a dislocated piggyback. So I think that was a gold mine of cases. And I think essentially the main reason why a piggyback would, dislocate or, decenter is zonular dehiscence, as George said. So, and you can never be sure, because these are all complex cases, and you could, 10 years from the time that you place it, you could go ahead and have zonular weakness, and the lens could dislocate. So I think you have to treat it as it comes. You have to see what kind of lens you have. And, techniques have evolved so much now that you could actually, some people have actually passed sutures through the optic, through the haptic. There are so many ways to bell the cat, I think. So depending on what kind of lens lies, in the piggyback, is the piggyback lens, or if it goes behind. So you could modify your technique with the number of techniques that we have today, sir.
Kamal?
Yeah, I think most amazing videos, Dr. Beko. As Gaurav said, I agree with him. A lot of times the reason could be a mismatch sizing. Maybe at the level of primary surgery, how much of pressure or force we exerted while pushing in the piggyback. What was the reason for requirement for piggyback would be that during the primary surgery, if there's excessive aggressive maneuvers of rotation of the nucleus and chopping, and maybe it was a hard cataract, so you end up breaking the anterior zonules. And on top of that, you put in a piggyback lens. Point 3 would be in case you used a piggyback lens, which has probably got a squarish edge. Not in the case of a 3-piece lens, but yes, a lot of times across in my practice, I see doctors who put in single-piece lenses, hydrophobic piggyback lenses.
Oh, God.
I explanted 2 last year, operated by some of the colleagues. So I guess these are also reasons, because the square edge lens haptic sitting in the sulcus is the recipe for disaster waiting to happen. So apart from these reasons, of course, there could be some innate reasons at the preoperative stage where the surgeon himself was operating could have caused some dehiscence of the zonules. And I agree with Dr. Beko, the lens has a unique tendency to find the dehiscence and will rotate into that area with the eye movements. And over long
like
duration,
the PRL.
Yeah.
It's like the PRL, remember? I mean,
absolutely.
it just reminded me of the PRL.
Absolutely. No, I've got a good experience with the Sulcoflex lens, and we have not seen this at all because of the overall diameter is much better. And also it sits in the sulcus so beautifully, this Sulcoflex lens. And let's go on to the speakers quickly. Sri Ganesh, you have any experience with the Sulcoflex or the piggyback? Kumar, if she is not there.
Let me unmute,
Yeah,
I just unmuted.
Yeah.
I use the Rayner Sulcoflex. The only thing with the Sulcoflex is the haptics are very long. And I've had lens where the haptic has torn while injecting. So now I prefer to put a phakic IOL like an ICL, and that works beautifully as a piggyback. Very nice videos, George. And I was thinking, of course, you can also do a M&A technique now, or you can also do iris suturing to anchor the haptics if it's a 3-piece lens. So these are 2 techniques also which you could try in such cases. Otherwise, you can just expand the lens and put in a phakic IOL to correct the refractive error.
So I tend to go away from iris fixation because iris suturing, because I find that I get a lot of CME with that and a lot of problems long term. And so I don't do that. In these cases, these were all situations where the patients had good vision with their piggybacks. So I was reluctant to go in and to exchange it for something else. I think going forward, we're very lucky right now because we have a bigger range of powers. You know, you can get up to 60 diopters and you can get down to -6, -7 diopters. So we have a whole different situation, but we will still see these cases from before. And as I said, each one of these was about 10 years out from their surgery, the primary surgery. I'm sorry for the quality of the videos, but you know, you don't get these cases that often. And sometimes
I know it's really fantastic surgery, but Sri Ganesh, see, please understand, I wanted to, because you raised this point, we're putting an ICL in the sulcus.
Yes.
The pseudophakic sulcus is different from the phakic sulcus. If a multi-piece lens like an Acrisoft lens or a multi-piece lens of J&J is going to dislocate, okay, in a pseudophakic, this thing, I'm sure the phakic ICL also, that is the conventional star ICL, whatever it is you're going to use, that's also going through.
See, if there is a zonular dehiscence, then there is a risk of it dislocating.
Can I add something, Dr. Mohan?
But sometimes you can also have a dislocation of the piggyback lens if the haptic comes out. For example, in the 3-piece lenses, sometimes the haptic just detaches. And if that happens, or if the haptic is deformed, then you can have a dislocation or a decentration. And that's when you want to do an exchange. If there's a zonular dehiscence, it's better to fix the lens and not to just exchange it, because if you put another lens in the sulcus, again, it's going to be prone for dislocation.
The chances of dislocation is more with the phakic the ICLs than with the multi-piece lens, because it is thinner and there's a possibility of going through.
No. Can I add something here, Dr. Mohan?
Yeah.
Okay, I agree with Sri Ganesh totally. See, the thing is, if there is a dehiscence, anything will go through. But still, the tendency of a phakic lens to go through is slightly less, because I believe I have a large series of piggyback phakic lenses, which are IPCLs. I've done more than 21 of them, and they behave better for the simple reason, it's a much softer material. The landing pads are thinner and soft. They curl rather than cut through the zonules. Another thing is, the planning of sizing is always 0.5 bigger than what I would have used for a phakic eye. I use a 0.5 to 0.75 millimeter size bigger in my pseudophakic eyes, and it works beautifully because I have a large deep chamber, which is approximately 5 millimeter or above. And I also want the lens to be actually sitting onto the sulcus. So I plan a 0.5 millimeter larger size than I would have if I was just planning a simple IPCL for my patient who didn't have or didn't require a piggyback. I'm going for a 0.5 millimeter size larger. But of course, if there is a zonular dehiscence or zonular loss pre-existing, anything will go.
Anything will go in.
Kamal, the other point is in a phakic IOL, you have a 4-point fixation.
That's what I'm saying.
Unlike, so you have a 4-point fixation, and yes, four points of fixation. Plus, you have a much deeper AC, so you can use a extra size. So, like you said.
Right. Okay. Kumar, you would like to say something?
No, it's all
Anybody else? Somashila?
I have used the Rayner Sulcoflex. As you mentioned, the haptics are large. Theoretically, it's a single piece, but I loved George's idea that you are refitting the same lens because then the calculations out of the whole window. And the patient was very happy with the same IOL for so many years. So refitting it, solves all the other issues of calculations. So that I think was a brilliant idea. And as she said, you can put change the technique, Yamane, whatever way you are comfortable, you can go ahead and do it.
Yeah. Anybody else want to comment on this particular technique of what George Beko demonstrated just now?
I just want to highlight one thing. If you have this situation and the lens in the bag still has an intact posterior capsule, deal with that because when you have the two lenses later on, it's very hard. So, the second case where it was posterior and the other one where I sutured the two together, if you're able to deal with the posterior capsule, get before you do any of these procedures because later on it's hard.
Did you do some vitrectomy also for the second case?
Yeah, you do. You always have to. Whenever you go into the vitreous, you have to do a bit of vitrectomy, but in 1 minute, you can't show everything.
Okay. That's fine. I think we had a very good discussion on this very, very beautiful video of George Beko. Is always so different from others, and he always comes up with something very unusual. And George Beko always gives some very good messages. Thank you, George, for always being with us. And
thank you.
I hope you are staying back for the rest of the session as well. So I will go on to the third speaker now. Third speaker is Dr. Sujata Mohani, Executive Medical Director of Rajanekar Hospital, Chennai. And she is really a versatile surgeon. She does, except for retina and oculoplastics, she does everything in the eye, cornea, cataract, refractive, glaucoma, and phakic IOLs. And all these, she's a very good surgeon. She's got a lot of publications and she's an excellent speaker as well. And today she's going to talk to us on a very, very important topic. Over to Sujata. You can start sharing your screen, Sujata.
Okay. At the outset, I'd like to thank IIRSI and Dr. Mohan for giving me this opportunity. So this is a case of aphakic bullous keratopathy, for which I have done a DSEC, a glued IOL with SFT. So this case was a 60-year-old female who was referred for management of aphakic bullous keratopathy. She had a history of nucleus drop during phaco, followed by pars plana vitrectomy. She had a large dilated pupil on presentation. So the plan was to do a DSEC with a glued IOL as well as a pupilloplasty. As you can see, I'm sitting temporally in this case, and I'm marking the cornea just to make sure that we are placing the lens centrally. And two flaps are created in preparation for the glued intraocular lens. And making a sclerotomy. And also I'm doing multiple side port incisions so that it will facilitate me during my lamellar keratoplasty. And now the lens is being injected. Using a multi-piece lens, my preference is you have to use only a multi-piece lens in a glued IOL. And this is getting fixated into the sterile pockets. And now you can see the pupil is large and dilated. So the next step would be to do a single pass four-throat pupilloplasty. And you can see that I'm using a microforceps to stretch the iris so that it allows me to take a nice bite using a 26 gauge needle so that this can be railroaded into it. And then the 10-0 proline needle along with the suture is pulled out. A second instrument is used to retrieve a small loop of the iris of the suture, and it is passed through the loop 4 times. So basically we are trying to tie the knot outside, but it's just a fourth row so that it doesn't slip out, and then you stretch it on both sides, you get a very nice knot. And you can use a micro scissors to cut the knot. So next, this side also needs the same thing. So I'm passing a 26 gauge needle through the iris and railroading it and using it as a fulcrum. And so again, using a second instrument to retrieve one side of the suture, make it into a nice loop. And you can see very clearly in this how many times we are passing the suture. So you have to go around it 4 times. That's why it's called as SFT, that is a 4th rows. Once you've done the 4th rows, the knot becomes stronger, and then you can just pull it and then again snip it off using the micro scissors. So now that the pupil has become smaller, the next step would be to do a desec. So I'm using the anterior chamber maintainer. I'm removing the damaged decimates. Using an air gives a little bit of, you can see the decimates being removed even more clearly. So because since I have not stained the decimates, this will be much more easier to visualize. And using a sheets glide, on top of which I put a high density viscoelastic, using the push through technique to introduce the lamellar disc, injecting air, and by repeated tapping, you can center the graft. And after that is done, use the tissue glue to seal the scleral flaps as well as the conjunctiva. So the pearl here is that in this case, postoperatively, the patient did very well, as you can see. And the pearl here in this case is that doing a pupilloplasty is very important so that the pupil becomes small size, otherwise air management will become difficult. And not only that, when you're going to implant a lens and with a large pupil, the chance of glare and the patient's quality of vision can suffer. So doing a pupilloplasty and a single pass 4-throw pupilloplasty really works very well and quite easy. It can be done by anybody. And it's a very simple technique to learn, and it works very well. So that is my pearl.
Dr. Mohan, you have to unmute yourself.
Yeah, I've done it. Thank you very much, Sujata. You have shown all the techniques in one video, the video of glued IOL, the SFT, as well as the DSEC as well. I was wondering whether, I just wanted to comment on 2 aspects of your technique. One is you are doing SFT, okay? The glued IOL is fine, no problem. The SFT, you are taking a 26 gauge needle because already there is a iris atrophy on both sides. I could see that. Okay, the iris is a little thin there. Okay, and you are taking a 26 gauge needle on one side and you are taking it onto the other side as well. Sometimes this 26 gauge needle can produce a big hole in the iris, and sometimes the iris becomes a little more, because it's atrophic there, it can tear there as well. So what is your take on that, number 1? Number 2 is, I feel that your pupil is not adequately small because you're doing a DSEC. You need a good tamponade for that. So when I saw the postoperative picture, it was not adequately small. So what is the optimal size of the pupil you aim for when you're combining a DSEC along with the SFT or a pupilloplasty, number 1? And what is the take-home message for preventing a hole in the iris or tear in the iris in an iris which is already atrophied and already thin?
Okay. Point understood. You know, the difficulty is that when you, if you notice that you use the microforceps to hold the iris. So there's a less chance of pupillary tear. It's very difficult to pass the 10-0 proline from one side to another. So unless you hold on to something. So that's the reason why I use the 26 gauge needle through the iris. Yes, it's a good point that it can definitely tear the iris if care is not taken adequately. So if you use a microforceps, the chances of tear is much less. If you use the microforceps to stretch the iris and then pass it through that, then chance of tearing is much less. That is the answer to the first question.
Yes.
The second question is that in this case, because the patients had the vitrectomy done and already had a nucleus drop, I didn't want the pupil to be too small because then it will be difficult to examine the posterior segment in the late postoperative period. So that's the reason why I didn't make it a very small pupil. I just made it adequate enough so that the air management postoperatively will be good. Because it's a vitrectomized eye, it's also a very soft eye, and the air will not hold if the pupils are not small. So that's the reason why I gave a large enough pupil, but not too small. That's the reason why in this particular case, I didn't make it very small.
Plus, the glued IOL is also a good scaffold for that. Along with the pupil, the glued IOL is also a good scaffold for the air to.
Yes, absolutely.
So it's always better to do the glued IOL first and then do the SFT and then go ahead with the DSEC.
No,
we go on to,
DSEC should be the last thing to be done because you don't want any endothelial damage. If you're going to do DSEC first and do the other steps, the chance of endothelial damage will be more. So whatever you're doing, you do everything and then you put the graft as a last resort.
Absolutely. Absolutely. I think the point is well taken and beautiful videos and nice messages as well. Let me go on to the panelists. Gaurav, as Maipal, welcome Maipal. Maipal, welcome.
Hi. Yeah, sorry, I was just held up. I haven't heard this thing, so don't ask me a question, sir. Welcome.
No. She showed glued IOL, SFT, and then DSEC, Maipal. So, which is it's a regular walk in the park case for you. I know that.
I don't know what.
But I want your. You've not seen the video, I suppose.
No. So let Gaurav do. I'll participate.
Gaurav. Gaurav. Yes. Gaurav, let me know. Let me take from Gaurav.
Yeah. So, sir, I think you are unnecessarily pulling on Dr. Sujata. She showed such a beautiful surgery, and your presentation is like 1 case, 1 pearl, but she had 1 case and 10 pearls. So, so I think she did a beautiful job. But yes, the question is very relevant. Sometimes the iris is atrophic, and you will get a buttonhole, or you can even get a tear of the thing when especially if you tighten it too much, or even while passing the 26. So what I typically try to do is I try to engage the iris. 1 pearl, she already said that you use the microforceps to hold the iris so that you don't tear it. But the second thing you can do is that you, with the 10-0 needle, you can come very close to the place where you want to pass the suture and use the 26 as pressure, counter pressure, engage the knuckle of iris where you want to pass the suture and push in the. Sorry?
The second portion, I showed that.
Right, exactly. So that is one thing which, she already showed. And I think that's the way that you can avoid having a bigger hole in the iris using the 26 gauge. And I actually use that for passing both sutures, So I pass the first one and then I withdraw the 26, come back and come to the other side and pass the second one also like that. So that way I use the 26 more as a guide rather than, going through the iris itself. That sometimes helps. And yes, I had the same concern as Dr. Mohan about the size of the pupil, not otherwise, but specifically for a situation where you're wanting to inject air and prevent that air from going behind. Otherwise, you did a beautiful job, but I just thought that since I'm not a cornea surgeon, I don't know what would be the ideal pupil size that you would want to create for that. But I think you already answered that. So thank you so much.
Now, if Amar is online, I would like to ask him what will be the ideal size of the pupil.
Actually, if you're looking for the quality of vision, you may want it a little smaller, but otherwise, I think it was adequate.
I think 4 millimeters would be ideal. 4 millimeters is ideal for pupil size.
Yeah. Anyway, Kamal, you have any suggestions? Is he there?
For the moment, he's not there. Maybe we should ask.
Hey, Maipal,
Dr. Somashila is a cornea. Actually, Dr. Maipal is already. I think you can ask Somashila. She's a cornea surgeon. Yeah.
I know. Maipal is there. Maipal will take his comment. What exactly you do while doing SFT when you already have a thin iris, an atrophic iris? Do you take that same 10-0 or 9-0 needle across the railroad technique, or use a 26 or 27 gauge needle on that side?
No, you can use a 26 gauge needle because I think that is better, but I don't, I use the forceps, I think, which was being talked about, and you have to be very gentle and hold it. And what happens is that you can either take one needle from this side and 26 and put it there. So that's something that helps. And if you have to really do encirclage, then you'll have to hold it with the micro forceps and do that. But normally the pupil, you can just by putting one or two sutures, you can actually bring down the pupil. I don't believe in the pinhole pupilloplasty that much that I want to bring down the pupil to 2 millimeters. I would rather agree with Dr. Shri Ganesh, a pupil of around 4 millimeters is good. And that also helps when you're doing a DSEC at that particular time. The air, it keeps the air in the anterior chamber and it helps you give a good tamponade. So that's the technique that I follow. I don't really bring it down to a pinhole, as Amar would say, get it down to 2 millimeters or something like that.
Yeah, I think she aimed at about 3.54 millimeters. It's good enough. Somashila, you have anything to say? Somashila?
Yes, I have been. Yes, I've been seeing the video, and Dr. Sujata, wonderful video. I think you really have covered almost all the points as Gaurav pointed out, and really left nothing for anyone to discuss. The similar, as I think most people mentioned, as Gaurav also said, that instead of pushing the 26 gauge through the iris, what I would also do is simply railroad the 10B root and hold the 26 gauge right next to the exit. And well, you can hold with a forceps, you can hold the iris and then make sure that it's more controlled that way. But over a period of time, you can just push it through, and just at the exit, you have the 26 waiting to receive it, and so you don't go through the 26. But you showed in the inferior, when you were doing the SFT inferiorly, you did not have to push the 26 gauge needle. So for this technique, I always felt that instruments are very important. Typically, I don't depend much on instruments, but here you have to have good instruments, especially the microforceps should be good and holding the iris. So just prepare with that. And Dr. Mohan, you asked about pupil size in terms of the DSEC.
Yeah, DSEC.
The air in place, yeah. Yes. So it's now known very well that if you don't have a small pupil, then sometimes it could be a mess. Sometimes it could be a real disaster because the iris goes behind and pushes up. The air goes behind and pushes up the iris, and you can even have like a pupillary block or an aqueous misdirection also, glaucoma next day. So because of that, now I've realized, and we've all been doing that, it's very important to make the iris small, and 4 millimeters is a pretty good size to balance between, to have a good examination of the fundus as well as to have a good air in the anterior chamber long enough.
Okay. Anybody else has got any other suggestion to make?
You should ask George. George has a lot of experience with this. Yes.
Yes, George, tell me.
Sujata, it was a fantastic case. You're a great surgeon. I'm not as good as you, so I'm always worried about the DSEC dislocating posteriorly. I think a good idea for surgeons like me who aren't as good as you is to put a suture through the DSEC material, 10-0, and then once you're happy with the placement of that DSEC, then you can just pull that suture out. Because sometimes that material can go behind the iris and fall into the vitreous, and then it becomes a much more difficult case to do. So that was the only thing that I would add.
I mean, you do it in all the cases because this had enough support. Iris was there and also the lens was there, so there was no need for it. If you're doing on an aphakic eye or a very large open pupil, then probably putting a suture would help. But do you think in this case also it deserves to have a suture?
No, what I'm saying is I think for you, because you're good at doing this, it's not a problem. But somebody who's just starting out and who hasn't done many cases, I think it would be worthwhile to do that because, these things do happen.
Absolutely.
And even if you have a small pupil, it can happen. And so, it's not a difficult thing to do. It's not hard to pull that suture out.
Okay. The DSEC flap dislocating into the vitreous can be really messy. And yeah, Kamal, you have anything to say since you're back online now?
Yeah, I'm back online. There was some trouble with the bandwidth. Now, can you hear me?
Yeah. But you can't see you.
Okay.
Right, fine.
Okay, I just said Dr. Jodhata's videos were excellent as usual. One small tip, just addition. When we're trying to go through the iris, and even if it's atrophied, holding with forceps, as Shri Ganesh said, this is a tip he gave me 2 years ago. I used to do my processes with the 26 gauge needle. He pointed it out. One thing I've learned is the nearer you hold it to the place where you want your 10-0 needle to go through, smaller the hole you'll have. Otherwise, there's no use holding the iris even with the forceps and you're trying to enter somewhere far away from there. You still land up with a larger hole. So go as near to the place. That's the time you get a very controlled, small little hole to tie the suture.
I think that the reason why I pointed out that is because the iris was a little atrophic and thin.
Absolutely.
Well. And while holding with the microforceps also, please don't try to pull the iris. Don't try to pull the iris. If you pull the iris, you can end up in a lot of problems there. It can be really make your life more and more difficult. If you have no more questions, any questions online?
No, boss.
Okay.
Sujata, yeah, go on.
Anybody else?
Yeah, Sujata, excellent procedure, excellent video, and I think you left Mohan speechless for some time after your presentation. And only thing I wanted to ask you is you could use a Boussin's glide. I find that that's less traumatic than sliding it on the glide.
Yeah,
so that's just one point.
I used to use a Boussin's glide, but I think it's a little bit big and it's a little bit cumbersome. Nowadays I don't use any glide. I just put it on the conjunctiva and I push it.
Nishant, you have anything to say?
Dr. Mohan, only one question. Yes. I'm not getting any questions, so this is peculiar. I've still got no questions. So I hope the link is active. There's still no questions.
Because there is some problem with the link. Can Rahul or Raman, can you check the link whether it's working active?
Because no question till now.
Ravishankar?
Yes, sir. It's
only questions coming are on the ones people who in the waiting room or they've checked in, not on the portal.
Okay. Anyway, let me welcome again Dr. Mahipal Sachdev, the president of the AAOS and the chairman of the Center for Sight all over India. And he's got more than 50 centers, and it's always a pleasure to have Mahipal with us. Mahipal, I gave a beautiful introduction about you in the beginning itself before you came.
Thank you. I know you always do a great job introducing. Except you don't introduce Sujata well. That's it.
Anyway, we go on to the next speaker. The next speaker is none other than the Phaco Maverick. Sri Ganesh, as you all know, doesn't require any introduction. And he is the CMD of Netra Dharma Group of Hospitals in Bangalore. And very, very dynamic cataract and refractive surgeon. He's got a fantastic tertiary, a super specialty eye hospital. Very innovative, powerful speaker. Fantastic human being. And very good surgeon as well. Very rare to get a very good combination like Sri Ganesh. And it's always a pleasure to have Sri on board with us. Over to Sri.
Thank you, Mohan, for those excellent words. And thank you for inviting me. I would also like to thank IIRSI. And let me show you my case. Okay, I hope you are able to see the screen now. Okay, so I'm just going to talk about IOL explantation, and there are many reasons why you may have to explant an IOL if you put in the wrong power IOL, or if there is a refractive error, if there's a decentration or tilt, then you may have to, or even a multifocal lens that the patient is not happy with, you may have to exchange it for a monofocal. So there are various techniques. So I'll just go through the initial commonly used techniques, and then I will show you my technique. So you can completely section the IOL or partially section the IOL. Here you can see that we are supporting the lens with the, through a side port with a dialer. And you can see this lens is damaged. The haptic is cut during insertion, so you have to explant it. So here I'm using a micro forceps to section the IOL. So it's very important to support the lens either with a dialer like I'm doing or with a micro forceps from the side port. But again, when you are sectioning and you put a micro scissor in the eye, there is a chance that you can hit the PC. So you have to be very careful there. You can section it through and through. Here, I section it partially, and then later on sectioned it through and through, and I've removed the two pieces separately. you can see that it comes out. But the disadvantage is that you will have to take the microforceps into the eye, and there's a chance of damaging the PC. This is another case where you can see this is the old Pharmacia lens, silicon lens. I pull out one haptic, grab the haptic from the side port for support, and section it 3/4 of the way. Of course, I put viscoelastic under the lens to push the PC away when you do this. And then you can grab the lens, bring it out and rotate it so that you don't have to cut it through and through. So these are the common techniques, but you can explant the lens now without sectioning of the IOL. You can remove it intact with this technique. So this is a case where there was a refractive error, probably because of mislabeling of the IOL or wrong IOL. So we needed to exchange it. So you can see that you just open. So the very most important thing here, what I'm doing is extending the inner lip of the incision. So the outer lip is the same, but you convert this incision into a trapezoid funnel-shaped incision. So here, this is the most important aspect. So the inner lip is extended almost by 1 millimeter. And then I'm staining the incision with trypan blue just to show you the shape of the incision. And now you can appreciate very well that the incision is a trapezoid incision. And it's like a funnel. Always, it's very easy to deliver a larger object through a funnel-shaped incision, just like in SICS when you're delivering the lens, or even delivering a baby, the uterus becomes funnel-shaped. So this is the lens, which is basically removed from the bag into the anterior chamber. You grasp one of the haptics, pull it out, and once it is out, you can see that you have a grip on the lens. Then you put in viscoelastic. I like to use viscoat just above the lens to protect the endothelium. So that is viscoat being inserted. You can see the difference in the viscoelastic. You can see the edge. Here I'm using the RTO, so it's excellent resolution. Then hold the haptic. Then you go in with a microforceps, just grab the optic in front of the haptic, and then you just have to rotate it. Here I'm rotating it counterclockwise so that it folds. And then the funnel-shaped incision accommodates it, and then you just have to pull it out. So you can see that the whole lens comes out. You can also use a hand-over-hand technique. And you can remove the lens intact. You can see the lens is intact. You're not damaged the lens. You're not introduced any sharp instrument into the eye, so it's much safer. And then you can just put in viscoelastic and then inject your new lens into the capsular bag. So this is a technique. The pearl here is to increase the incision. You can see the outer lip is 2.8 mm. It's the same size. It has not increased. And then you can see that the inner lip is about 1 millimeter. That's what we have extended it. So I'm measuring that. And you can see that it's under topical, so the patient is moving the eye. You can see that this is 3.8 millimeters, almost 4 millimeters. So this is a technique which I've explanted a lot of hydrophilic, hydrophobic lenses also. Any type of lens, even phakic IOLs. Of course, phakic IOLs are much thinner, like the ICL, so you don't really have to extend or make it a funnel-shaped incision. But if you want to explant any of the IOLs, then you make it a funnel-shaped incision, and then with this technique, you can very easily explant it. It is quite easy, and I think this is the pearl. Thank you very much for your attention.
Thank you. I think, thank you, Sri Ganesh, for the incredible stuff. Before we go on to the panelists, I just want to ask you one question. While explanting the lenses, I'm a little apprehensive about the posterior capsule, okay? So what I do always is do something like an IOL scaffold. I put the lens first in the bag, then try to bring this lens up in the anterior chamber, use a nice, good viscoelastic like Halon GV or Halon 5 to expand the anterior chamber, and then explant the lens, either whatever method you want to, either cut or hand-on-hand technique, whatever it is. The second question I want to ask you is, this the funnel technique can be done only with the hydrophilic lenses, if I'm right.
True.
You cannot
No,
make
you can do it for hydrophobic also. Even with the AcrySoft lens, it comes out very easily, in fact. This
Sure.
lens, which I...
Because the hydrophilic molds, in my opinion, the hydrophobic doesn't mold.
But the hydrophobic is thinner. This was a 25 diopter lens. This was a hydrophilic lens. But hydrophobic also, I have experimented. I don't have the video right now, but I can show you with the AcrySoft. Actually, it's very easy. It's easier than the hydrophilic lenses. And even the thickness also can be explanted. So any of these lenses, but the main thing is, the principle is the funnel-shaped incision. Of course, for scaffold, you can put in a lens, but the importance is if you're taking a scissor, micro scissor into the eye, then probably your technique of putting the second lens in first. After explanting the lens into the AC, then you put in the second lens into the capsular bag, so that supports and you don't damage the PC. But in this technique, that issue is not there because you're not going in with a micro forceps. Most of the maneuvering is just done at the incision and externally. So it's much safer than taking a micro scissor into the eye.
Have you studied the wound distortion postoperatively?
Yes, we have done the OCT. Actually, I showed you the wound also post-op, and we have done the OCT also. There's not much of distortion, and the wound holds very well.
Yeah. Okay.
But if you try this, without making the trapezoid or funnel-shaped incision, then you can have a tear and distortion. So it's very important to have the funnel-shaped incision.
So in your experience, you can even hydrophobic lenses, we can get
Yes.
Okay. George, you're online. I know you've done a lot of work on the L-shaped incision, even for a PMMA lens. Okay. Can you enlighten us on that L-shaped?
Yeah, so the L-shaped incision involves doing a 3 millimeter incision at the limbus and then going posteriorly from that. So that you have 3 at the limbus, then you're going back posteriorly about 3, and then you take your incision and you make it wider on the inside. So you kind of shave it for another 3 millimeters into the cornea and into the sclera. So there's overall width is about 6 millimeters, and then you enter into the eye, and that allows you to take lenses out, put lenses in. And there's no induced astigmatism. We follow these out for 2-3 years, and there's no change in the astigmatism. So that's the benefit of it. And in most cases, if you make that shelf well, you can actually don't even have to put a suture in. So that's the advantage of having that.
That is mainly for the PMMA lenses or for all lenses you do?
You can use, well, if you're going to use it for some of the other lenses, I mean, Shree's incision there is about 2.83 millimeters in order to do that. With what we're doing, we've got 3 millimeters, and you can make it up to 4 or 5 if you want, and then use the funnel, his funnel. So I guess we can sort of combine the two and do it that way. But the important thing is you have to tunnel into the sclera and into the cornea so that you have that big, wide closure.
Yeah, similar to an SICS, only thing it's L-shaped.
Yeah.
It's partly in the sclera and partly in the
SICS will give you about a diopter of astigmatism. So, you know, if you do the frown, there's been a number of publications. So it gives you about a diopter, whereas the L doesn't.
Yeah. Thank you, George. And over to the panelists. Maipal, what's your take on the Sri Ganesh video? And what's your technique for explantation?
Yeah, I think Shri Ganesh has shown a wonderful technique. Actually, the entire technique is dependent on the fact that how moldable is the lens.
Absolutely.
Also, the second part is the thickness of the lens. And the third part is the structure of the lens. If you are working with a 3-piece lens, it cannot work because you will pull out the haptic from the optic, and it would definitely not be able to give you that kind of pressure or this thing. And I think it's a wonderful technique, and we have been doing this very often for the ICL or the phakic lenses because they are much thinner, and that's not a problem. You don't even have to extend the inner lip of it. But Shri has shown that extending the inner lip, you can actually have enough play for the lens to fold on itself and to be brought out. The only one thing that Mohan, actually you commented, which I would wish to disagree a little, is that I won't use a GB or a 5 because that would come out as a bolus. And I also wish to protect the endothelium. So I would rather...
Both I use.
Yeah. So I would rather use
that has chondroitin sulfate doesn't come out that easily and protects the endothelium.
No, I use both, but I want to create more space also, apart from protecting the endothelium. That two things. Something short.
In a minute actually, because it will come out as a bolus. So that's something that I would prefer not to do that.
Okay.
That's about it. Otherwise, she is an excellent surgeon as always and comes out with new techniques. And I think it works well. It would work well more so for hydrophilic and thin hydrophobic lenses. Like he's talking about the Acrysof. Acrysof has a high
very soft lens
active index, so and it's much more malleable. So I would say it would depend on lens to lens, but yes, you might have to enlarge the incision a little bit more. But it is doable and a good technique.
Thank you, my father.
Yeah, Gaurav and Kamal. Kamal, you'd like to comment on that?
I say, Sri Ganesh, I saw your technique and it's wonderful, very innovative. And especially I like the way you give a reference of a birth canal or probably even a cartridge. Cartridge, it starts with a bigger bevel, a bigger funnel and ends down slower. My only submission would be, Acrysof, though being a hydrophobic lens, is a very, very malleable lens. This thing, at least in my opinion, would not work with a lens like Envista. You can't get away with a 2.8 millimeter wound with Envista because Envista has got super sharp edges. Number one. And I feel for those kind of lenses, because I do a lot of Envistas, I need at least a 3.4 millimeter outer port to get that lens out. Number one. Number two, hydrophilics definitely would be a far more easier walk with this trapezoid technique. But even if you go for a Technis, anything beyond 23, 24 diopters can be tricky with Technis because the Technis has an optic haptic junction which is thinner. So sometimes for a beginner, I think we need to put a caveat there that when you're pulling it out, it can break. But yes, this is a beautiful technique. It doesn't distort the wound. One parting word would be that the last part, as it's coming out, mentally we have to make sure that we don't pull it upwards because that's the time the lens starts tipping in and starts touching the posterior capsule. It has to come out at the plane of the iris. If that is kept in mind, I think it'll work most of the cases. Wonderful technique.
The problem is that you don't explant a lot of lenses. So I would love to explant an Envista. I would love to explant a Technis one. But the thing is, you don't have so many cases to explant. So over a period of time, probably I will collect and then have a collection.
First case was Envista,
lenses.
No? The first case was Envista.
That's when he cut it. That's when he cut it.
That was Envista. That I cut it. I cut it through and through.
I saw
Sri Ganesh, I use a lot of Envista, so I know taking out Envista is a little different ballgame.
Kamal, you have taken out hundreds of Envistas?
No, not hundreds of them, but yes, whenever I need to take them out, they're tricky. They're tricky.
Okay.
Yeah.
Dr. Mohan, I wanted to add a couple of points. I enjoy doing a couple of things. One is that for all our beginner surgeons or even for most of us, I think coating with viscoat or something similar for protecting the cornea and also making sure that the chamber is nice and deep and formed. These are two important things. And then, of late last few years, I like to inject my new lens into the bag before I actually do any maneuvers with if it is possible. I mean, it may not be possible in every case. And Sri Ganesh showed an amazing technique. I'm going to try it next time. It really looks really cool. But for now, my current preference is to use and I have no financial interest, I use the MST forceps, micro forceps and the MST micro scissors. The advantage is that you can go in from paracentesis with both instruments and very controlled way, the forceps holds the optic very nicely and you can cut across it in a very, very controlled way. The instruments are amazing and I feel that my investment is well worth it. I've been using them for the last 3-4 years. They've not gone bad after maybe 10-15 lenses that I've cut in.
The second case I showed was with the MST.
Right. So the advantages.
Yeah, I just want to have before you go to this thing, you don't have to cut through and through. You
don't
just
have to
cut 3/4 and then you can go.
It can just come out. You just dial it out.
3.5 millimeter hand-on-hand technique. You can probably take it out.
Absolutely. You don't need to cut it through and through. You leave a small connection and it just comes out. So the other thing I feel is that, people, sometimes I've seen people struggle with vanas and, going through the main incision and, trying to cut across the lens. I think that's not a great idea. And I'm sure some of the Indian manufacturers make equally good instruments like MST for, the micro scissors and everything. And we can easily, look for one and make sure that we use micro instruments. I think these are my few takes. But Sri Ganesh did a great job. Yeah.
Very nice.
Thank you, Gaurav. Gaurav,
I
you
have
should try it next time. Then you will throw away. Your
I'll do that. Yeah,
I didn't know Shrikanath was a good gynecologist as well.
Mohan, can I say something?
He knows the anatomy in and out.
More obstetrician, not gynecologist, obstetrician.
Obstetrician, whatever it is. Obstetrician and gynecologist.
Both.
Yeah, we go on to the any other comments from any other speakers?
George wants to say something more.
Yes, yeah, George.
So I think, your point about using the L-shaped incision as a backup is a very good one. And I think people should keep that in mind, that they can do that. The other point that I would have for Kamal is, if you use warm BSS, it actually helps to fold the Invista and it helps to fold the Technis material. So just taking your BSS and putting it in the blanket warmer and putting it in makes those lenses more pliable.
Excellent tip, George. Yeah, wonderful.
So I have a question to ask. I hope I'm audible here.
Yeah.
Yes.
Dr. Sriganesh, that was a great video. And all this COVID times, apart from ophthalmology, we are taking help from you for keeping fit. But with all these surgeries, I must have wasted so many microforceps because they lose their memory when you start holding these thick optic haptic junctions and optics. So, it's a serious burn on yourself when you spend so much money. And I've used across the spectrum from Indo-German to ICO to Epsilon. So what is the forceps that you were using to pull these, IOLs so strongly and still the forceps doesn't do?
The trick summarize is to hold the... No. This is the MST forceps.
MST.
But the trick is that, you hold with your left hand. I'm holding a MacPherson. So I'm holding the haptic with the MacPherson. So I'm exerting the pressure. See, the MST basically, which you're using in your right hand, is used to twist the lens and fold the lens more than exert the pulling force. The pulling force is exerted by your MacPherson, which is holding the haptic. So there are two forces, one with the MacPherson, which is holding the haptic, and the other, you also twist and also pull. So when you're pulling, you pull with both hands. And that is the trick. And so that's when you don't damage your forceps.
Thank you.
Nice. I think we, for a lot of time, I think we quickly go on to the next presenter.
I got a message from Dr. Namrata Sharma.
Yeah, Namrata is coming. Yeah, I know. I can see that. Yeah. Welcome, Namrata.
Welcome, Dr.
Nice to
Namrata.
have you, Namrata. And I would like to introduce Professor Namrata again. She's the professor at the RP Center. As you all know, she doesn't require any introduction. And she's also the secretary, a dynamic secretary of the All India Ophthalmological Society. And both she and Maipal are doing wonderful work in these challenging times of COVID. Thank you, Namrata, for joining us and sharing your expertise and knowledge with us as well. So we go on to the next speaker. The next speaker is actually a Bollywood star.
Next speaker is Mohan Rajana.
I know, that's what I thought.
Only he can be a Bollywood star.
Bollywood star.
Dr. Himanshu.
Himanshu Mehta he's a very, very prolific cataract and refractive surgeon and director of the Vision Eye Center in Bombay, Leelavati Hospital, Nanavati Hospital, incoming president of the IIRSI. And why I said a Bollywood star, with all the Bollywood actors are his patients, including Amitabh Bachchan, Shah Rukh Khan, Amir Khan, everybody. And even Aishwarya Rai, all the top people in Bollywood are Himanshu's patients. And Himanshu is a fantastic surgeon as well. And he's going to talk to us on a very, very important topic today. Himanshu, all yours.
Thank you so much, Mohan, for introductions. Good evening to everyone. We have had some very interesting session. I wanted to represent, I'll share the screen now, on suspended the IOL back complex, which has got subluxated. And that is something which we are going to see quite often, regularly. As more and more patients who have been coming to us with pupillary block and you have other problems, you will see gradually that they have the IOL back complex, which is kind of subluxated, dislocated into the vitreous. It's important how we can salvage this without getting the complex out, because the moment we touch it and we try and pull it out, we will pull the vitreous, we will pull the zonules, we can create a detachment and we can do everything. So the important thing is that how with minimum manipulation can we go at. So any trauma, pseudoexfoliation is one of the commonest causes, connective tissue disorders, inflammatory diseases. And you can see that these are patients who have a higher chances, and posterior dislocation of an IOL, as you can see, all of us have been facing them in the last couple of years more than what we have ever faced in the past. So the posterior capsular rupture, the zonular dialysis is present. Most important, the zonular dialysis is because of the improper fixation within the capsular bag. Now, patients of any of these conditions should be followed carefully. And if one notes significant constriction, if you feel there is a phimosis, how can we avoid this? If you feel that the phimosis is happening very strongly, you can yag the anterior capsule, so the pull on the zonules will be less. Now, here is a case classically where you can see a subluxated IOL. It's moving around. And if you can see what I'm doing, I'm trying to first, 1 second. Yeah, so as you can see, the IOL is there, and I am trying to, sorry.
Just play it, that's all.
Yeah. I wanted to pause it to show you that I'm trying to remove the additions between the iris repositor. With the iris repositor, I'm removing the addition between the IOL and the capsular bag. Once you remove that, you've made place for a future thing that you're going to be doing. Once you've done that, you measure the opposite 3 and 9, or whichever place the subluxation is there. You mark the two angles which are there. You can either create a flap, scleral flap, or you can make a small groove in the sclera, as you can see here, which you can be, where the sutures can be hidden in the end. Now, what you're doing over here is, with this side, you are passing a needle, and as you see, as you move forward ahead, 3 millimeters behind, you are passing a 26 number needle, which is now 24 gauge needle or a 26. You can hold it stabilizes your sclera, and this needle is passing between the IOL back complex from behind and near the haptic optic junction from the lower edge. And the 10-0 proline is being passed from the opposite side. You've already kept it pending over there so that you're ready for your next move. And as you move ahead, you hold it. Here is a very important step, very important so that you are giving counter traction with something. We could have a forceps or I'm using the dialer to give a counter traction on the IOL bag complex near the anterior capsule, the capsular rhexis area, and the needle penetrates through very well because there is fibrotic element. You have to be very careful that you do not subluxate the lens at this point in time. Once that is there, now it's becoming a lot more easier. You see the needle which has penetrated the IOL back complex from underneath, and it's coming from underneath and coming above the lens. So it's holding the capsule, the haptic, and it's coming above the optic over the rhexis margin. And a 10-0 proline or a 9-0 proline, which is now being engaged into it and railroading. So as you railroad it, you can take it out from that 4 millimeters behind, and that's now is a very important step which has done. And you can see that the IOL bag complex, the schematic, as you are going through, you're passing the needle and you are holding it. Once that is done, comes the second part, the easier part. The needle comes back now 0.5 millimeter, 1 millimeter in front of it, in front of the lens above the IOL bag complex. This is not holding anything. So you're making a U shape, and the second part of the needle, the second needle is getting into the 26 number needle, 24 gauge needle, and you are railroading it. And now you have two parts of the loop which are being pulled onto. Now see the important part here. You're not touching the cornea, you're not touching the vitreous, you're not touching the retina, you're not doing any fluidics. So the cornea is fairly simple. You're not creating too much of iris pigment problems. You're not touching the vitreous. You're not going to be creating a lot of traction on the vitreous base to avoid a detachment. And at the same time, smooth manipulation in a closed chamber. You can go ahead and remove the second part. Now, as you can see, the second part comes out there. And that's pulling the whole the bag on one side. Now repeat the same procedure on the opposite side. As you can see, the 24 gauge needle is going from this side. You're giving counter traction from here, and a similar procedure being followed because you have to have a traction. And you're passing the 9-0 proline into the 24 gauge needle, and one underneath, as I said, near the IOL bag complex with the haptic, and the other one above. And now you can see this is how the eye looks within 48 hours. There is not much of iritis. There's hardly any fluidic. You have kept, if at all there is vitreous in front of the lens, it's very simple to do a little amount of vitrectomy. The lens is still very strongly adhering there, and you have to be very gentle in manipulating. Since it's a closed chamber, you're not expecting vitreous to come out. You're not expecting the chamber to leak out very badly. And with some amount of viscoelastic, you can get away and close the wound. So even if you have a flap, you can suture it in the flap, underneath the flap, or a scleral groove with a conjunctiva on top of which will hide your prolene sutures. Now, this is just to repeat again. There is a second case. If here is a patient who also had some amount of cortex left. So it's very simple that you can go ahead and remove the cortex. And the same way, you are railroading now, as I said, you're past the 10-0, you're ready for your next move. You're going from behind 4 millimeters, you're just holding on to that. You're railroading that needle into here. Underneath the IOL back complex with the haptic in place, and now the upper edge. And this is how we can finish and that's what can be done. So this is what I wanted to talk about.
Very good. Very nice, wonderful videos, Himanshu. And I think you have given the techniques so beautifully. Only thing is, what I will do differently, I will create Hoffman's pockets. I don't take a scleral flap. I don't open the conjunctiva. I just create Hoffman's pockets on both sides. Makes life much more easier, less messy as well. And you said you go 3 millimeters from the limbus?
Yes, 3 millimeters from the limbus.
Yeah, you use 9-0 or a 10-0?
A 9-0 Prolene. But okay. I'm stabilizing the globe with a 24 gauge needle, which is bent by itself.
Okay, you are passing a 24 gauge needle
from one side.
On one side.
On one side, and I'm railroading from the opposite side with the 9-0 Prolene.
Why not a 26?
Yeah, that's right. I was stabilizing the globe because there was still movement in this case. As I said, that's why I was telling you between 24, 26. If you have a smooth eye, if it's got good amount of sedation there, and the eye is not moving, you can go ahead with the 26 number needle. Yes, you're right.
Okay. Let me go on to the panelists quickly. Namrata, how differently you would have handled this particular problem?
I think it was very elegantly done by Dr. Himanshu Mehta. And of course, it's a different way of doing it. And I think he showed very nicely how you have to stabilize the lens with your dialer when you're actually putting the needle there to give a counter traction. That was a good part to show. But I think I would agree with you on one matter, and maybe because now I've seen it, I might change my strategy. But Hoffman's pocket, I would also put if I had seen the case in the first instance. But I think very nicely, very nice technique.
I just wanted to reiterate one. This is minimum amount of fluidics, so the cornea is not very badly affected. The iris is safe, the vitreous base is safe, and you're fairly confident that you not pulled any vitreous behind, so I have any traction at the vitreous base.
Yeah, very nice technique. And Maipal, you would like to have some other view on this? How do you manage this late dislocation or subluxation?
You're not audible.
Not audible, Maipal.
Say that first of all, I would normally do it under a peripheral block. Well, am I audible now?
Yeah.
Yes, better.
Am I audible now?
Yeah.
Okay,
yes,
so
yes, Maipal.
the only thing.
Go ahead.
Yeah, the thing I was saying was that I would prefer to do it under a peribulbar block, and therefore piece lens, and if it does go back and subluxates or dislocates, then you have to handle it at that particular time accordingly. But
Maipal, if you put an endocapsular ring,
yes,
would it not be very difficult if the whole thing subluxates after that?
Yeah. Removing an endocapsular ring from the vitreous is so difficult.
But
it's not easy joke.
Yeah. So what you are trying to say is we are saying that maybe 2%, 3% or 4% of, I don't know the incidence, but there's a limited number of cases of pseudo exfoliation where the entire back complex falls back. So just you can't make the exception as the rule, because typically the endocapsular ring is giving a support in majority of the cases.
Absolutely.
Yeah. So the exception does not become a rule. Yeah,
absolutely.
Quickly, we go on to the other panelists. Gaurav?
Yes, I think Dr. Himanshu did a great job because, he made it so elegant. There's little left to explain for this particular situation. And then, I think the discussion about the pseudo exfoliations, good idea to put in the endocapsular ring, I would think. And just a thought as Dr. Maipal was speaking, why not put a double Sionis ring, in case you're thinking that there's going to dislocate, you'll have, two eyelets available to you anyway. I mean, it might take away some space in the bag, just a thought. But I think I would have handled this particular case exactly as Dr. Himanshu did, and he did a great job and a very useful technique for managing it. Hoffman's pocket was my point, but you stole it from me, so that's okay. And that's my favorite for a few years. And I think he did this case a couple of years back, so probably today, if he does it, he will still use the Hoffman's
He'd use
pocket.
the Hoffman pocket, yeah.
No problem. I think that the key is to go make sure that you pass one needle underneath the haptic, the other one above the haptic. Am I right, Himanshu?
Yeah,
and that is because you can
you're
have
holding
a
it.
loop.
Yeah, you're holding it.
Yeah, you're having a loop there. Okay, Kamal. Yeah, Kamal, quickly.
Kumar wants to say something. Kumar, go ahead.
Kumar.
Yeah. Excellent, Himanshu, your presentation. But 2-3 things. These patients normally come with a history that when they sit, they can't see, but when they lie down, they can see, because the lens and the whole back complex comes in the middle. So when they're lying down, they can actually see the ceiling quite well. So very important thing is, one is I would have preferred to use a Gore-Tex material if possible. And secondly, another important thing would be that very important when the patient lies down and you're given a block, make sure that you center the whole back complex and you get the same point. So your junction that you've selected to make the loop around has to be exactly the same point on both sides. If it is different on either side, then it's going to cause a lens tilt and a new different issue altogether. So it's very important that the patient lies down when we're doing the surgery, which we do. And then, of course, we have blocked the patient, but make sure that the points are marked. So I would prefer to mark it and then make sure that the needle goes to the same point and you maintain the same angle. And of course, the Hoffman pocket is what you said.
We marked it in the beginning, Kumar.
Yeah. Always use the Ashwin Agarwal marker, 0-180. So make sure that you are marking that very well before you start. So, Kamal, you have anything to say?
I have a point.
Yes.
I have a point. Okay, I guess Dr. Himanshu, amazing surgery.
Not audible.
There was such a surgery. One query. Sometimes, as Dr. Maipal said, I agree with him totally. If the subluxation is asymmetric, see, in your case, it was kind of symmetric. So you could probably go from one area, and when the suture was coming out from one, bang opposite, you could go and catch the looping the other plate, other haptic from the similar area. But in case you already made your 2 ports, and the lens is actually now not exactly bang opposite, the first suture is going from
Kamal, your voice is breaking,
haptic,
Kamal.
but the other one is not going from there. So you may have we may have an asymmetric hammock effect. It's not going from the similar places in the haptic area.
That's why I said you could have a tripod. You might have a third one to support you at a time like that. You're right.
Yeah, another good idea.
One more point I'd like to add is, we were discussing the pseudo exfoliation. I agree with Dr. Maipal. In all my pseudo exfoliation cases, I've started putting a CTR. There are 2 benefits of a CTR. Of course, it stops the pressure of the zonules, being broken. So one thing for a pseudo exfoliation, always plan a little bigger rexis, because if you have a smaller rexis, the tendency for a capsular phimosis and further breaking of more zonules, number 1. Number 2, when you put in the CTR and you go with the procedure like this, you have a far more symmetrical support to go through when you go through the needle, rather than just the haptic. You have also the ring also supporting the whole capsular bag. So 100% agreeing with Dr. Maipal that putting in a CTR in these cases is a good idea, because not all of them would fall on the retina.
And also, it's a good idea to use iris hooks and dilate the pupil, because many of these pupils don't dilate.
May not dilate, yes.
Please understand,
Absolutely.
they're all pseudo exfoliation. They don't dilate very well, and you need to make sure that you see the periphery very clearly when you're passing the needle up and down. So that's, I think, a good take-home message. Nice video. We go on to the next. Any questions from the audience? Kamal.
I'm still getting a blank. There is a huge issue with the questionnaire. Just the same. Last question I get is, please, Dr. Mont, keep planning more of such webinars. That's the last statement I have.
Kamal, I think you have to refresh it, because I can see quite a few questions, but most of them, somebody has actually put in like 20 of the same messages. Any specular data on different techniques So this is from Dr. Sanjeet Shah, and he's posted it about 20 times. And so I don't know what that he wants to know whether there's any specular data.
I got a link from Ravi Shankar.
After this, you can take some questions.
I'm getting the link from Ravi Shankar. I'm getting the same question again and again.
No problem. I will I have the pleasure of introducing the speaker number 6. You always hit sixes. That's the reason why I put him at 6. Because this guy is really a fantastic surgeon from Bombay, director of the Dr. Eye Institute. And he is a very dynamic cataract and refractive surgeon, powerful speaker, and fantastic surgeon as well. And very innovative and a lot of lateral thinking. It's always a pleasure. Every time in every conference, he always comes up with something very new. And I'm sure he'll have something new today as well. Over to Kumar Doctor.
Mohan, why have you not introduced him as a Bollywood star?
Because all his patients Himanshu has taken.
He's an absolute star by himself. Look at that picture.
He himself is a star.
He's a star by himself. He does.
Who is taking the Bollywood patients? He is the Bollywood star himself.
He's a star himself. Absolutely.
Thank you, Mohan, and thank you, Amar, and the whole team of the Implant Society. I'm going to show two different things. I mean, it's one case, but a discussion on this will be quite interesting. All of us see this now, okay, and we are all going to face this. So on the left side, you can see iris clip IOL. Some of us done this. This was the varices phakic IOL and a cataract inside. The right side is another phakic IOL. You also have the star ICL or the Indian ICL, the IPCL, the phakic IOL made by biotech. Now the question is, if all these phakic IOLs come out with a cataract, what are we going to do and how do we handle this? So foldable ICLs and they have a cataract, what next? Non-foldable ICLs and they develop a cataract, what next? So what can we really do here? So this is a case of a foldable IOL, you can see, where it's quite simple. Made an incision taking virion into consideration, and I've rotated the lens vertically so that it can be removed. Now the incision was 2.2, I'm making it 3.2. Now this is an old star ICL done by me many years back. I'll show you a video at the end of it. And now I'm going to bring this ICL into action. So I'm opening the old ports, making sure that there is viscoelastic supported, and then get the plates into the anterior chamber. And now I'm going to use the same forceps. I'm putting viscoelastic below the ICL, supporting the lens from below and putting viscoelastic above the ICL that's protecting the endothelium. Once we've done this, now go in with the same star ICL forceps, which is to use the lens, which is used actually to grip the star ICL and then hold it and then pull it out. So here the incision that I made was about 3.1 or 3.2. So you can see that I'm holding the ICL and then getting it out. There was no central hole because this was done many years back. Once I've grasped it, just pull it out, and then one can go ahead with our routine cataract surgery, and it's quite easy to manage. So here, of course, the incision was made with the virion technology. So I made the incision at 90 degrees and then removed the ICL with holding it. Here you can see that it's being held and then just pulled out. Now it's quite easy. You can see the wound well made. Do a CCC, go ahead and do your CCC, do your phacoemulsification, then do IA, whatever method you want. Once you've done that, go ahead, the bimanual IA, go ahead and put the IOL in the bag. So this was quite easy. This will happen over the night. I'm going to show you the last part of this video where it shows that when did I do this ICL many years back. And that's what I luckily, the patient had the data. This is just the bimanual IA and then put an endocapsule ring because I felt that the bag was not very good. These are high myopic patients, some discussion that we had on this part. Once I put that, go ahead and put the IOL in the bag. So now I'm going to just remove the viscoelastic, and the last part of this video is about the date and what I had done it. So you'll see that on 24th of July or June in 2002, this was done by me, and you can see this 24th of July, 2002 was the ICL when I had done this, 2002, and it was a minus 22.5 diopter star ICL. So that time they did not have the central hole, and that's the reason why there was a little iridectomy on the side, and you can see the diopter power. So this was as far as this goes. But now the question comes when you have a non-foldable phakic IOL in place. Now what to do? Because these are non-foldable, you can't cut them in the eye. They are made of PMMA. This is the varices IOL. So now I made a 2.2 millimeter incision, gone ahead and done a side port. And now the question is, I have to do phaco, I have to do IA, I have to remove this, and then put in another IOL. So if I'm going to do this before, and remove the IPC, remove the varices IOL before, then my wound is going to be 5.1 millimeter, and that's not going to be enough. So what I've done here is made the main incision, gone ahead, done my rexis. After doing the rexis, you can see that I'm running parallel to the size of the optic, which is 5 millimeter in size. Done my hydrodissection. Once I've done my hydrodissection, I'm going to go ahead and with phaco. So now I'm doing phaco below. The only care I've taken a little bit here is to reduce the bottle height. You can see the bottle height in the right corner is normally 106. I made it 54 centimeters. So that pushes in less fluid, and that's a big advantage. Go ahead and do phacoemulsification, remove the nucleus. Once I've done that, I make my second side port, and then I remove the cortical material with bimanual IA. So you can see that I'm doing bimanual IA. Once I've done that, go ahead and then remove this varices phakic IOL, non-foldable 5 millimeter in size. So here I'm going to do bimanual IA, remove all the cortical material. Once I've done that, put in the viscoelastic, create your backspace, and then disengage the claws of the iris. And the technique there is very, very simple. What I'm going to do is, you will see here, just removing the cortical material now. Once I've done that, I'm going ahead, making two side ports. You will see the side ports being made. These side ports has to be in the area where there is the iris which is enclaving the claw. Once you've done that, this is the side port that is being made exactly in the same area. So this is the same needle that we, or the spear that we use on both the sides. Once I've done that, there is a special varices forceps, which is actually a claw, two behind and one in the front. And now I'm using the same port just to make sure that I'm holding on to the eye. This is all under topical anesthesia. And now I'm going to enlarge my wound. And once I enlarge my wound, I'm going ahead and holding the varices forceps. Now you can see that I put an iris repositor. With the left hand, I'm holding the IOL and then pushing the claw towards me upwards and pushing the iris repositor downwards. That is to disengage the iris from the claw. So that's a one-step procedure, very easy to just disengage that. Once you've done that, do the same thing on the other side. You can see that I've removed the iris from the claw. Go ahead again, hold on the other side, and now hold the claw. You can see this is a special varices forceps, which was given to us many, many years back. And now I'm disengaging the claw on the other side, remove the iris from there, and then rotate this lens, because at that diameter it's 5.5 millimeters. So now I'm rotating the phakic IOL and then removing it out from the eye, going ahead and putting a foldable IOL, which is anyway, whichever lens the lens measurement is. And then I like to take sutures in such cases, because that will take care of the astigmatism calculation, which will be necessary at that stage, and then do a bimanual IA and remove the viscoelastic. So the take-home message here is, if you're foldable or non-foldable, if it is foldable, you really don't need to worry about the calculation of the ICL. Foldable, a small incision, it can just be removed. A good tunnel and same forceps to grasp the ICL will remove that. As far as they're non-foldable, I thought that we do phacoemulsification and irrigation aspiration underneath the ICL, then remove the ICL, that's a non-foldable, the iris claw varices, and then we can go ahead. Just care, as I mentioned, was to reduce the bottle height. Go ahead and put another foldable IOL, and then at the end I would like to take a suture so that it prevents the astigmatism and the calculation that was done. Thank you all, and thank you Mohan and Amar and Gaurav and Maipal.
I think it was a brilliant presentation as usual. Kumar, I like your glasses as well. It's a night vision glasses. What you are using? Anyway, but the first case, I want to, before we go on to the panelists, the first case, you enlarged the incision to about 3.2?
3.1, 3.2,
because I could see some iris coming out during your photo.
Yes.
So I was wondering whether it's possible to enlarge, remove these lenses with 2.8.
It should be possible.
Yes,
It should be possible.
Yeah, it's possible. The second case, normally when I have an iris claw lens in the eye, okay, I find your technique is also very good. You have shown that you are underneath the iris claw lens, but what is the impact on the corneal endothelium, because you're pushing this varices lens forward during a phacoemulsification, number one. I always put a scleral incision and try to remove the iris claw lens, and then probably put one suture and then go temporal clear corneal, then do the phaco and come out. So that's my way of doing it. But let us ask the panelists, maybe many ways to skin the cat. Maipal, what's your take on that?
Yeah, so basically, Mohan, I would agree with you that there is no harm in doing a slightly posterior limbar or a scleral incision, putting a suture and taking another incision and doing the rest of the surgery. I don't know, Kumar completed the entire surgery. He should have also gone ahead and put the intraocular lens and taken out the virus size after that.
Yeah.
I don't know.
Makes sense. Makes sense.
I think, Kumar, you had done it. You had not used femto. I think we published a similar case with a Versailles lens, but we used femto to make the rexes and also to make our chops. So, that kind of still eases out your surgery. But yes, and we had also disinclavated from one side, but that endothelial cell loss problem is there because it may rub onto the cornea. So what you need to do is keep pushing it in viscoelastic, maybe a viscodispersive type, so that your endothelium remains protected. But
Yeah,
we've published this case.
that's the only apprehension I had, Namrata. You read. Maipal, you wanted to say something?
Yeah, I wanted. So first of all, Kumar, I would rather remove the lens first and obviously do a specular before doing that, because a lot of these cases would have a poor specular count. The second thing is that what Dr. Namrata mentioned was about the femto. Sometimes the femto recognizes the lens as the capsule. So you have to be very, very careful about that, because you can have a cut that was shown by Dr. Ramamurthy. And I have also, at times, you may not be able to get a good capsulorhexis that is there with a femto when you have an ICL in place. The first case that you said, I do not prefer to use this thick beaked forceps, because you'll need to have a larger incision. All you need to remove an ICL is to put viscoelastic, just levitate out the ends and just bring out one plate, the haptic edge from one plate, and bring it out. And I normally use two capsulorhexis forceps, or the other forceps, a McPherson usually slips, but if you have a capsulorhexis 2 forceps, you can do easily a hand over hand technique like what Shri had shown you, or you could, nowadays I have also started using the smile forceps. The smile forceps also gives you a very good hold on the ICL, and you don't really need to extend it at all beyond 2.8 millimeters. So any of these forceps which gives you a good, you just need to take out one edge of the plate, and you can easily pull it out. So I won't go in with a thick beaked forceps, because I think that is the reason why you actually were struggling to put it below the ICL, and you possibly needed to enlarge the incision. You can very easily manage it through 2.8. Obviously, you are a good surgeon and you can do these things, but these are small 2 variations that I will have from what you showed.
I think beautiful message, Maipal, and go to Kamal and Gaurav.
Yeah. I think Kumar, as usual, a phenomenal surgeon and a phenomenal surgery. Just 1 or 2 points according to the surgeries we saw. In the first case, where you're taking out a foldable phakic lens. I agree with Dr. Maipal. You don't need to enlarge the wound, probably because of the forceps or the technique you were using. You probably needed to enlarge the wound. What I do is I push in the viscoelastic. Since if I'm making a fresh wound, I make a tunnel which is probably 0.25 millimeters smaller. Then all I need to do is the leading haptic of the phakic lens, which is supposed to come out, that I de-enclavate. And then I push my scleral lip. As my viscoelastic comes out, I invariably get 1 or 2 edges of the knob coming into my wound. Then all I need to do is go in and hold it with McPherson and it comes out. Works every time, it works. Number 1. Number 2, in the second case where you operated, I don't have an experience of doing that, but I've done a lot of cases of phakic foldable lenses, did a complete phaco, rexis, everything underneath that. I think you might have seen those videos where I've done everything underneath the phakic lens and then explanted the phakic lens, because the 2 of these cases are very high myopes with very low scleral rigidity. And I had used V1 model of the IPCL, which was far more rigid, and it required a 3.2 millimeter incision to be removed. The V2 requires 2.8. But then it works. But yes, Dr. Mohan Rajan is right. It can cause endothelial damage. So the tip which I did use in those cases was I used frozen HPMC on top of the phakic lens. And then I started doing my irrigation aspiration. And after every few minutes, I would push in some amount of, cold chilled methyl cellulose on top to coat the endothelium. Why I use a cold chilled endothelium to cover the endothelium is because it's far more viscous doesn't come out easily, and it coats the endothelium very beautifully, and it works every time. So these are two small little tips I have.
I think one important message Maipal has told is do a specular for all these patients.
Absolutely.
With
True.
iris claw lenses and varices lenses. Very important before you take this patient up for the phaco and explantation as well. Now, Gaurav?
Yes, I think, yes, George, go ahead. Yeah.
George.
Can I just share my screen for a second?
Yes, yes, L-shaped.
I was just wondering if there's any evidence to say that chilled HPMC or chilled viscoelastic is going to cause less endothelial damage.
No, it's not about the endothelial damage, Dr. Namrata. I was very clear. It's far more viscous. It doesn't come out easily. Just try it. Try pushing out a chilled viscoelastic through the syringe. It's far more hard to push.
You can use viscoat, no, for that.
Yes, you can. But in case this is a tip for all the other beginners, you can use a little bit frozen HPMC. It's far more viscous. It doesn't leak out easily.
Yeah. Go ahead.
Do you see it?
Yes.
Okay, so this is the L-shaped incision. Originally, when we did this 20 years ago, was when we started doing the artisan or the Verisize lenses. And if you make that incision and then do this tunneling, it allows you to take those lenses out without using any sutures and not inducing any astigmatism. So it's this 3 by 3 and then by 6. And you can take the complex out, but you can also take out those Verisize lenses or artisan lenses through that incision. So I just wanted to show that to
beautiful. Very innovative, George. I've seen these videos and in all the conferences, really fantastic innovation. And Gaurav, you have something to add?
Yes,
on that?
you know, I think everybody's already said everything, but there was only one thing which I wanted to add, that sometimes if you're using a very small incision, like I use a 2.2 incision, and to remove the ICL, you need at least a 2.8. So, you know, what you could do is that, and sometimes you make a 2.8, by the time the ICL is out, it actually becomes a 3 or bigger. And so sometimes you'll have a leaky wound, just like Kumar got a little bit of iris prolapse. You can abandon that incision and make another small 2.2 incision and just use that. You don't have to suture this one because it will be sutureless. So that's another, you know, like a rescue thing that, you know, you don't necessarily have to go through an incision which is slightly bigger. You can just, you know, change your main incision and complete the phaco from another incision as well. But I think all the other tips were all great, and Kumar showed some excellent videos.
Yeah. I think
I just want to say one thing, that one is, of course, I've done specular for these cases and they've done very well. The second point I want to make is I always use viscoat to protect the endothelium. And if you see during the surgery and during phaco and IA, the lens is quite steady. The iris claw lens is not very volatile. You don't lose your chamber. The only reason being my bottle height was low. So if you maintain the bottle height a little lower, you're not pushing in too much fluid, your iris is not going to balloon up and your iris lens is not going to come up. So that is going to protect itself. So if you saw the video, the lens was quite stable. It was hardly going up and down, up and down. There's no volatility in the chamber at all. So this is just one take-home trick that I did. And I've done both eyes and the patient's doing it.
I understand. But the problem in high myopes as well is that the fluid misdirection can happen. And that can go underneath the iris and push the iris forward. And if it's going to push the iris forward, the lens is also going to go forward and hit the endothelium.
Mohan, just one comment.
Come back.
Kumar, excellent video. And I think this technique has been published where this is the preferred method for the Verisize lens. And it's better to do phaco than remove the lens. Because if you remove the lens through a large incision, then you can't maintain the fluidics. So that's a very important point, that you can do the phaco with the lens and then later on you remove the lens once you've finished it. And of course, if you combine it with the L-shaped incision, then there's no need to suture also. And the publication says that the endothelial damage is less with this technique, because if you put viscoat between the corneal endothelium and the Verisize, then the lens does not move up. And then even your fluid currents and the lens does not touch the endothelium. The endothelium is actually acts like a shield for the endothelium, and it's already published. This is there. So they have already done specular microscopy and found that the endothelial damage is not much.
We published a couple of cases of this type in Journal of Refractive Surgery, but with the Verisize we used femto also. So we used femto to make the rexes, femto to make the
I've seen that publication. But another important aspect is not to disenclavate the haptic, because if you disenclavate the haptic, then the lens tends to move. So you should not disenclavate the haptic. Complete the phaco like Kumar showed, And excellent video, Kumar.
Very nice, very innovative. Namrata, you have any change? Do you change any settings for the femto when you're doing?
You have to, because you have to offset it a little bit. Because you have to put it on the capsule, so you have to. So like ICL may, may itself get cut with the femto, that it will not happen with various size.
Fine. Thanks a lot. And we go on to the next speaker. Since we are running short of time there, so the next speaker is actually doesn't require any introduction at all because she's so famous. Dr. Somashila Murthy, and she's from LVPI Hyderabad. As you all know, she's also the member scientific committee in the AOS now. She's the head of the cornea and the anterior segment. And Somashila is the most popular consultant in LV Prasad, according to all our students. And she's a mentor for many, and she's a guide for many, and she's also a friend and a philosopher and guide for many. And Somashila is a very dynamic cornea, cataract, and refractive surgeon. We have seen her in surgical strikes in Chennai quite often, and every year she comes and demonstrates some lovely surgeries, small pupils, phakic IOLs, and all that. So over to Dr. Somashila for her slightly different video. Somashila, all yours.
Thank you very much, Dr. Mohan Rajan. I'm just about to share my screen.
Yeah.
And first of all, when you said that very popular, so I thought it wasn't me and I was relaxing again. So, and very, very generous introduction. Thank you. You've not met my students who don't like me also. I'm sure there are many of them. But it's been wonderful. I think this is the first time, as I was telling Gaurav, that I'm participating in this particular forum. And I'm going to bat from a different wicket. So my one case, one pearl is going to be on refractive surgery, and I'm going to discuss femtoflap complication. It's not so much as one pearl from this, but probably it's a difference in opinion or difference in management that many of us would have when you come across, it can happen to anyone, a complication like this. So let me roll in the story of on a beautiful day, a 32-year-old software engineer decides to come in for refractive surgery. And we had tested him before. His visual acuities were improving. This was his refraction with -7.
I'm not able to see your video.
I'm not yet started the video. I'm just
I'm sorry. Okay.
in the text at this point. And this was his refractive correction for the right eye and left eye. Nothing very out of the ordinary. And
no, have we shared your screen?
I have shared my screen.
I'm sorry. Okay. Sorry.
Maybe there's some lag. Can you see my screen? It shows you that there's a 32-year-old software engineer.
Nothing.
No, nothing is seen. That is the reason why I'm telling you.
Nothing is seen.
Your screen is not working.
I'm seeing only your beautiful face.
Okay. That's not enough.
You have to share your screen.
Just share your screen and...
yeah, I'll try again. So...
yeah, that's right. Better now. You're able to see now.
Yeah.
You can start from the beginning.
Yes. So this is about a case of refractive surgery. Since everybody are such masters at cataract surgery, I knew I couldn't do better than them. So I decided to shift gears. And I'm going to talk about a case of a femtoflap complication. This is not so much as a single pearl, but more to probably discuss what are the various kinds of management that others would do in this particular case. And this is the kind of management we did for our case, who's this very nice, pleasant 32-year-old software engineer. His refractive correction for the right eye was -2 cylinder and -7 spherical, and left eye was 6.75 with a 0.75 cylinder. And he did have extensive lattices in his retina, which he underwent laser for that and everything done. So he came in for surgery. And of course, he had to go overseas and things like that. So already time was running and he wanted everything done perfectly. His corneal topography is just to show that it's just so green and pleasant to look. Everything was good about the topography. There's no danger over there. So this is a surgical video. The patient did have, in retrospect, we thought what could be the factors. He did have deep set sockets and slightly prominent brow and a large nose, but was a very cooperative patient. And so this was the first eye that although the patient did move a little bit while the femto laser was going on, unfortunately, we don't have a recording of that. But we could see the raster going very well in place. At no point was suction lost. So the surgeon was very confident that the flap would have been dissected as per plan and nothing is amiss. So the surgeon is going in and just opening up the flap as usual. And it's a little sticky, but the surgeon is very confident that everything will be fine. You can notice that there's some subconch hemorrhage over here, and the eye is a little deeper, deep set socket. So as a surgeon dissects out the flap from superior part and goes inferiorly, suddenly what he notices is that there's a tear. And actually, it's not just a tear. He first thought there's a tear, but it's not just a tear. What has happened is that there's a whole segment inferiorly that has not been dissected at all by the femtolaser. So there is a point in the LASIK flap where there is no dissection at all. So the surgeon is now not panicking, just trying to explore and see whether it's dissected, but it is separate, it's a separate piece, but no, doesn't fiddle with it anymore. And now has just lifted this and is still thinking about what to do next. So he immediately tells the patient that there is a slight problem with your flap in your right eye, but I think that there are two choices. We can either proceed or we can stop, and what would you like me to do? So sort of with an educated patient, you can do that. And the patient consented. He said that, go ahead, I trust you, doctor. So if you notice that the central pupil is right here, and there's an adequate space even below it, perhaps you have a 6 millimeter optic zone. So the surgeon went ahead and completed the laser without any problem as far as just firing the laser was concerned. The surgeon then comes back and is going to deposit the flap back into place. So it's just moistening both ends of the flap and puts it back into place. So that was not very difficult actually. So what the surgeon is doing, and this is, I've edited it, but took a good 7 minutes to complete this part of it. First, simply just put it back in place and saw that this particular edge is going to roll up if that's all the surgeon does. So the surgeon pushes that little edge back, so wants to seal this completely. At no point do we want the epithelium to be rolled outward. And so this is done multiple times till the surgeon is very, very satisfied that the entire anterior surface is looking like a single unit. So again, another wash is given. And again, the inferior areas explored to make sure that the surface is very smooth and it's almost in continuity, that there's a single kind of plane in continuity. Once again, the tissue is put back into place, making sure that the epithelium is not rolled outwards. So in the very end, we placed a BCL on the eye, and the routine postoperative medication was started for the patient. The left eye was uneventful. There was no problem there at all. So this is the placement of the BCL. So what happens on the first post-op day? The patient was very comfortable, but his visual acuity in the right eye was not as clear as the left eye. He was 20/30. And what we could see on the slit lamp photograph is these epithelial cells, but they were not really in the interface. If you can see here, a slightly brighter curvilinear line, that was the edge of the area which had broken through or cut through, and their epithelial cells, but this was below the BCL. And because when you remove the BCL at 1 week, these cells were no longer there, nothing was there. So just to go through his follow-up visits, at 1 week, he was about 20/40. At 3 weeks, he actually improved, he was 20/20. Again, at 2 months, he started complaining of colored halos in his right eye. And his visual acuity now started bringing in a cylinder in the right eye. But 5 months when he came in and he said that his halo had decreased, we had started him on brimonidine for his halos. And his visual acuity at 5 months was about 20/25 with a 0.25 spherical and a 0.5 cylinder. And just to sort of take care of this small amount of myopia, we kept him on timolol eye drops and of course lubricants. So this is the OCT at 1 week. And what I want you to look at is the edge. So here you have a very nice routine kind of LASIK flap coming in. And this is already 1 week after the lens is out. So the inferior part actually has a dissection plane, but it was at a different level. So the level was not the same. And this must have happened because the patient did move his eye, but we never lost suction at any point. So the laser continued to do the dissection, but at 2 different levels. So it's a good thing that the surgeon didn't try to dissect out this plane with sharp dissection. And then at 1 month itself, if you take a cut through the vertical aspect, you can see that everything, you can't really make out what's happening. It'll be very hard pressed to say that this patient had really had any problem at all. So we had a very good outcome for this patient. This is his topographic map. The anterior surface shows a very good smooth kind of map, which is comparable with the other eye. So that was about my case. I'll stop sharing my screen.
Yeah, very nice demonstration of that complication, flap complication, Somashila. I just want to know, you did the right eye first and then went to the left eye.
Right.
Okay. And what was the problem of incomplete? What is the reason for the incomplete flap in the right eye? Number one. Okay. Number two is, since you had a complication of an incomplete flap in the right eye, you do not know what exactly is the reason. Does it make sense to go for the left eye?
So the surgeon here has, so we all have a typical practices. So my practice is to do femto laser on one eye, then complete the eczema laser part, and then go on to the next eye, do the femto flap, and then complete the eczema part. But the surgeon here finished the flaps on both the eyes. So he had already got the femto flap in the left eye as well. And then the table was flipped to the eczema laser, and then he brought in the right eye and started dissecting the flap and was ready to do with the eczema laser.
Okay.
So that's
at that time only he realized.
That is when he realized, yeah, the other
right.
eye flap was already done. And even at the time of the femto flap, when it was being created, there was really no hint to let us know that things could be amiss. Patients do move their eyes a little bit, but as long as you don't have suction loss, so you assume that, and then when you see the raster pattern as normal as it usually is, so you assume that you're going to have a regular kind of a femtolaser pattern for this patient as well. So there was really no hint or no clue at that point to figure out that we're going to land into trouble with one eye. Okay, and of course, as you said, your second question was that, yeah, I guess you were alluding to when you know that there's a complication. So,
yes, right.
Yeah. So
why you should take up the second eye? That's the reason
exactly,
why.
Yeah. So that's,
I didn't know that you had done flaps for both eyes.
Yeah. So still we could just abandon and not do and wait. Put a BCL, not do anything, and come back in later. Probably go in with PRK, transepithelial. That would be an excellent option. Maybe we could have done the left eye. So these are there are guidelines, of course, but the discussion in the patient should be involved in the discussion. And so this patient had a concern of traveling, going overseas. Of course, he came back probably because of the pandemic coming up. So he came back in March most recently, but otherwise he was due to go overseas for quite a while. And he was available to us for at least 2 to 3 months after the surgery in India. So we discussed with the patient, and it seemed to be reasonable at that time to go ahead and complete this surgery.
Okay. Thanks, Somashila, for the nice points. Let me go on to the panelists. Namrata, can you tell me what exactly has gone wrong in this case?
I think we need to see the raster pattern, I think, to be able to say that. That is something which is, important before you realize why that area was uncut, or whether the patient has moved, or was it really a superficial cut as opposed to the cut which was being made. So I think that that surgical video is important to see. And I would not have continued with the case, and to not ask the patient also whether I should continue or not, because I think that decision rests with you rather than, with the patient, and would have taken the case at a later date. Of course, it went off well at the end of it, but there can be irregular astigmatism in cases like this, which could be very difficult to, tackle with colored hills and multiple other problems. So it is a way of tackling. And I think that epithelial ingrowth, Somjula, I don't think comes at day one. I've not seen, others have seen, I don't know. It generally takes some time, for the epithelial ingrowth to come in the interface of a LASIK flap. At least a month for the epithelial cells.
Yeah, these were probably epithelial cells, maybe.
Just debris, debris sort of a thing, which
debris,
is
that's right.
Behind the GCL. And I think it is not a good practice to do 2 flaps together and then 2 examer laser, because you have both the eyes with the drapes like that. And then, both the eyes are open, and then do the flap of the one, and then, do the examer. It is best to complete one eye and then do the other.
I think, Namrata, for that, you don't have a choice. It depends on what femtosecond laser you're using. I was going to ask Somashila that what femtosecond laser you were using.
Yeah, we use the FS200, but still,
in that you can actually do complete the procedure, both steps on one eye, and then do the second procedure. But like I use an intralace, and on the intralace, because I have to move the patient from one room to the other. So you have to do both femtoflaps and then wait for some time for the OBL to go away and then take them up both for. So sometimes you don't have a choice, but sometimes you do.
But OBL, that way is not a problem with FS200.
Yeah.
We don't have to wait
No,
for
it's not a problem. But in the interlace, because like I have a wavelight and I have an interlace, so you can't kind of shuttle the patient twice.
Doing both eyes makes it much more simpler than shifting the patient. I also have a FS200, and doing an femto is a semi-sterile procedure. Whereas when you're actually opening the flap, you can drape the patient. I don't drape the patient while doing femto.
The first part is done without draping.
Yeah, without draping. The second part, when you then you can flap and then you can zap. You can do both flaps together and then you can come in and zap.
We drape at both the instances, whether
Yeah. Okay.
So in fact, Dr. Mohan, can I chip in with one important point?
No, I want to ask Kamal and Maipal, what do you think is the reason for this? Do you think the hollow sunken eyeball is something to do with the complication there?
That is what I was wanting to ask, because I don't have any personal experience with FS200, but majority of almost all the femto flaps that we have done, it is under direct visualization. So I think the FS200 would also allow you to see the entire procedure of where the raster beam is passing and things like that, right?
It does, sir.
Yeah, it does. So we can see the entire raster pattern, and it seemed like
the problem is that under these circumstances, there has to be either a vertical gas breakthrough, because even if there are two separate planes, what you are trying to say, it is not as thin. The point is that
absolutely.
It is not really that basically there might have been a small adhesion, but you should be able to see a cold spot there. Were there any cold spots at that particular area, uncut areas, or any vertical breakthrough that would have been seen? Well, it should be visible. So that is one part of it. So without seeing the femto part of it, the video of it, I will not be able to comment at all as to why it has happened. Normally, majority of the machines, once you lose suction, they stop. Yeah. So
here, yeah. So
the suction was good. That's what you said, no?
So yeah.
Sorry.
So the couple of points here is, unfortunately, I apologize. I don't have.
Typically, even if there is a movement, the suction is strong enough for it to continue in the same plane until, of course, there is a pre-existing corneal opacity. I also have a video which I often show, is that there was a nebulomacular corneal opacity.
Absolutely.
And there I had a vertical gas breakthrough bubble. I could see the burping of the gas, and I knew that there is a vertical gas breakthrough bubble. And that is why there was an uncut area. And when we were dissecting, it didn't go well into the same plane. Now, depending upon how peripheral is this, I would have a slightly different opinion from what was said earlier, is that the harm or the damage of an uneven flap has already been done.
Yes.
Whether you are zapping it or you are not zapping it, it is not going to make any difference in the epithelial incidence of the epithelial ingrowth, because whatever damage had to be done because of the irregularity of the flap, that has been done, as long as that is not impeding on the visual axis to cause a refractive effect. So maybe this was slightly bigger, but if it had been a slightly smaller one, I would not have hesitated to go ahead and do that. The only thing that I might have manipulated is that I might have reduced the optic zone from 6 to 5.5. So that the whole area where I'm doing the excimer ablation becomes slightly smaller, leaves that particular area. But yes, I will put a contact lens. I may not put it for a week, maybe 2-3 days is sufficient enough for it to handle. And the only thing that you have to take care is the epithelial ingrowth in such particular, because the periphery, it's like you have created another hinge, as I would wish to say. So that would heal pretty well, and the results are pretty good. So you have to evaluate before you are starting to lift the flap as to what went wrong. So I don't have the video, and you say that everything was fine. So that is a little puzzling for me as to why this would have happened, because I have not seen such kind of thing, or there was a pre-existing corneal opacity which was missed. So those are the only things which are there.
So I have one question, Maipal. Do you think the dissection, though it was at a different plane, if it had been done a little bit more gently, it could have, this wouldn't have happened? I think it was.
No. I don't think so. Video on a slow motion, because I think it was a lift that went not in the plane but went up, and there was a area, and it tore the flap. Actually, he or she, whoever has done that, I think that.
One is that we'll still try to pull out the femto part of it. I don't have access to it, and I've.
What was the flap thickness?
So it was 110, preset at 110.
110, 120. It doesn't seem to be a very thin 90 micron flap.
Can I add something?
Yeah, Kamal, quickly, and because we are running short of time.
I think I would tend to agree with both Dr. Namrata and Dr. Mahipal for a simple reason. If the triangle of the uncut tissue was larger, I would have not done the surgery. But as Dr. Mahipal says, the damage is already done.
Yes.
In case it was smaller, you could reduce the optical size, beautifully explained by Dr. Mahipal. I've had 2 cases like that. The possible reason in those 2 cases, when I went back and saw the files, was there was a sheet of mucus under my PI, patient interface, which did not, where the laser didn't go well. And it was being operated by one of my surgeons who was just new at femtosurgery, and I was called to the theater. In one of the cases, since the triangle was large enough and it was not making any sense for me to reduce the thing, luckily I had a 90 micron flap. So I put the flap back and I went in to operate another day after some time, 30 microns deeper than that. Now, in the other case, since the triangle was small, what I did was I just dipped my mirror seal. Now, people may raise eyebrows to that. I dipped my mirror seal in alcohol. I just, at the edge, I touched it for a few seconds. I made sure I washed it away, and then I peeled away the epithelium from there, and I completed the surgery with a complete 6.8 millimeter optical zone, and it worked fine. But the triangle of tissue was small. And you have to be very careful. It shouldn't spill over onto the bed of the
You should also know the pupillary size before
Absolutely.
you use the optical.
I think it's a beautiful message which is Somashila has given, because we have to be aware of this complication and probably prevent this complication, and probably how to manage this. Namrata, I just quickly, since we're running short of time, suppose you are not done the procedure at that time, what you would have done later?
So
for this patient
would have taken the patient later. Of course, she said, according to Somashila, the patient was overseas, so you couldn't wait. But I would have taken the patient after say 3 months for a repeat procedure.
How differently you would have done at that time?
I would have. I'm sure there must be some problem. The patient has either moved the eye, or some problem is definitely there. So we would have just prevented that it doesn't happen, because if one eye has gone uneventfully, I see no reason why it didn't, go uneventfully here, except for the fact that probably the patient moved the eye. And the pupillary zone also has to be
very important.
Size of the pupil is important before you decrease the optic zone to, say that you can still go ahead with it.
I think that these are the kind of cases that we'll have in real life.
Yeah.
And whether it's at whatever stage you may be. So my typical tendency is that if I have a flap-related complication, I don't proceed. If it's the first eye, I don't even touch the fellow eye. So come what may. But so we are known as the senior surgeons now. But the younger generation, and also because the fact remains that the patients are extremely demanding. So this plays on the doctor's mind as well when we are doing such cases, and you feel that most of the time the results are extremely good. Like even in this case, the reason I presented this case is because I think that if it had happened to me, I would have not proceeded with the surgery, and I wouldn't have done the other eye either. But having gone ahead and done the case, I think it worked out very well. It just shows that the cornea is very forgiving, or the conditions of the pupillary size, the optic zone, those things were actually fine. And that's how it worked out. So it was a very risk, it was a gamble, but it was a calculated gamble, and it worked out in this particular case.
Is it a good idea to ask the patient, or you decide? Because when you ask...
The idea is to keep the patient informed, but depending on the, how psyched the patient already is and what is the patient's personality. So based on that. So the idea is to say that something is not right. I think honesty always works, but of course, there's no point in painting a dismal picture, but a little bit of honesty in terms of at least saying that this is the thing, and so that I think honesty always works in such situations.
I just wanted to share a very quick point.
Yes.
What was shared was that there is some problem with the interface. I had a very unique problem where the PI, the interface which was there, got fogged up in a particular area. So either it could have been mucus or it could have been anything else.
Similar.
There was something.
So Kamal was telling that only.
Correct. Kamal said something was blocking, and I had fogging of that. So something definitely blocked that area.
Yeah.
No, but Himanshu and Kamal, the only thing that I am limited point that I am trying to make is if there is something in the interface, there's a debris, there is mucus, or even if what you are saying is that there could be fogging of the, or there is something that is stuck onto the interface, you will see that the raster has not gone there.
Absolutely.
You will
Absolutely.
see it. You can see it. Yes,
I said when I went back, I saw the files, it was there.
On table, I noticed it. I noticed it on table.
Yeah, so then you are wiser whether to start lifting the flap at all or not. Because if you see a large enough area where you know that there is an uncut area, then you can do a trans-PRK at the same sitting at that particular moment. Or if you want to postpone it, that's fine, but you can do a PRK at the same moment.
Agreed.
Without touching the flap at all. Because you know something has gone wrong with the flap.
Yes.
Both situations, I was called in the theater once it happened.
Okay. Thanks, Maipal and all the panelists for the wonderful thing, and Somashila for the nice, beautiful video. I think it's it's an eye opener for all of us. And we go on to the next speaker since we are running short of time. Dr. Samresh Srivatsa, again a very, very young fellow and very dynamic cataract and refractive surgery, refractive surgeon of Raghudeep Eye Hospital, Jaipur, Ahmedabad. If you ask somebody question how many times Samresh has won the ASCRS and ESCRS awards and even the grand prize, I think in the ASCRS, it's probably the most number of times by any Indian, because his videos are really out of the world and everybody knows about it, the quality of the videos, and is very, very innovative and always comes out with very new thoughts, new inventions. And so over to Samresh for this video. Samresh.
Thanks a lot, sir. And thanks for inviting me for this webinar, and thanks for calling me young. It's always very encouraging that way. So I'm going to keep it very tight and very short. Now with all this COVID, I'm only getting mature cataracts and posterior polar cataracts. And so this is a case when, sometimes you'll be thrown these weird cases, and this is a patient, young female, who lands up with a unilateral posterior polar cataract. And when she comes to the clinic, she has the posterior capsule that is already ruptured. It's a pre-existing defect. It's rare, but I think everybody in their practices, all the senior doctors in the panel would have seen a few of these cases. This is just to show you, this is the area of the open posterior capsule. We decided to do a femto in this, but that's not the point of the discussion today. We have a technique called femto delineation for posterior polar cataracts. But in posterior polar cataracts, the idea is to build up avoid the buildup of hydraulic pressure inside the eye, so as to avoid any posterior bulge of the posterior capsule and make it worse. My point for bringing about this case is to show you the optimal use of parameters. We are driving the car over here, and the phaco machine is just for us. So it's very important to understand all the parameters well. Now this is a Centurion vision system which has an active fluidics, but to understand this, there's a very low IOP, which means there's a very low bottle height of about a 30 or a 40. And I have very, very low parameters running because I don't want to deflate the globe too much to be able to. So otherwise I'm going to rupture that small zipper that's open in the posterior capsule. The idea, like I said, I don't do any hydro maneuvers if I can avoid it with the femto. If at all, I'll do an inside-out delineation to just delineate the nucleus from the epinucleus area, because you're really worried about getting the nucleus drop, not the epinucleus area. And once you remove the nucleus, I always do a viscoelastic exchange. So this is viscode and exchange. Remove your instruments only when you fill up your capsule, your compartment. So there's no anterior bulge. Again, I wanted to bring about the use of low parameters because you want control and absolute control at this point in time. So I'm using a very low IOP and I'm using a very controlled vacuum of about 150, 200, now slowly bumping it up because it's in a linear control, and a 14 cc flow rate, which is a very, very low flow rate. Again, if you notice, before I exchange my hands from left to right, I inject viscode to inflate the chamber again and remove the remaining cortex on the other side. And this is the amount of control that a good fluidic system, or even if not a good machine, but a good understanding of the machine fluidics brings about in your hands. And once you have done this, notice this is a small area of posterior capsule defect. And because you could salvage that area, because you could save that posterior capsule from enlarging the defect, you can now use those micro forceps that we've discussed so elegantly previously in many talks to convert that ragged posterior capsular excess, ragged posterior tear margin into a continuous curvilinear capsular excess. We could do that in this case only because of experience. We learned that if you go slow, like when you're driving fast, there are chances you'll meet up with an accident. But when you're driving slow, you have immense control in your vehicle and you can actually target what you're hitting. And so we were able to save the posterior capsule from enlarging and splitting like a zipper. And once we did that, we were able to convert that ragged edge into a continuous curvilinear posterior capsular axis and it's no-brainer to understand that a round margin is a much stronger margin. Because we knew we were able to deliver this, obviously because there can be vitreous, it's a good idea to stay in with triamcinolone. My choice of vitrectomy is generally a pars para vitrectomy, but I'm just going with the limbal vitrectomy here because in certain situations with the limbal vitrectomy and bevel turned upside down, you can get enough clearing in that area. And because I knew more likely that with my technique of low parameters, I'd be able to commit to a patient with a high astigmatism, and this is a patient where anybody, I was scared for the umpteen number of times I've been scared to commit to advanced technology IOLs. But with advancements in technology, but more importantly, with understanding and clear understanding of fluidics, you can now commit these patients to advanced technology IOLs, a toric, a high toric, a T7 in this case. And notice how elegantly the lens is sitting, well centered, continuous, all around surrounded by a good capsular excess margin, which could be a manual capsular excess, although it's a femto here, and that really doesn't make a difference if you're a good surgeon. And this is how the patient looks 2 weeks post-operatively. So things could have gone south in this surgery, but we were able to control it. And my one case, one pearl is you please use your fluidics right, especially for the junior surgeons. You don't want machine parameters. You want to listen to the machine and you want to listen to your surgeons on how to optimize your machinery to your optimum performance. Thank you.
What a wonderful video, Samresh, and what a lovely take-home message. And suppose you have a patient with a mature cataract and you do not know what exactly is happening.
Yes, sir.
Patient posterior polar cataract. How do you know pre-operatively? This patient you were able to see the break pre-operatively.
So I mean, I generally say for me, the other eye is a big takeaway. So people look out to the other eye, either a badly done surgery or a sulcus lens if they've been operated elsewhere, because generally that's when they turn up to me, or maybe a posterior polar cataract, which is quite evidently visible. In a mature cataract, for me, the OCT does not penetrate down to the posterior capsule level. So we tend to use a UBM for all our mature cataracts to look for posterior capsule integrity. And a B scan also sometimes gives a giveaway of a fishtail sometimes. So trying to do and see at every angle possible by whatever mechanisms you have. I understand that it's, some people will have a B scan and some people may not have an access to a UBM. But if it's a mature cataract, I anticipate a defect and I move accordingly and prove myself wrong otherwise.
Absolutely. I think the important message, what Samresh told, I want all the panelists as well as the other people to, this thing is, look at the other eye. If you have a mature cataract, look at the other eye. If you have a lens in the sulcus or an ACIOL or an iris claw lens or some vitreous disturbance, probably it's a posterior polar cataract. You have to be careful in doing the hydrodissection in this case. And UBM is one way. I do in all these cases, whether it's a pre-existing or a confirmed posterior polar cataract, I do only femto nowadays. I want to take over the questions to the panel now. Maipal, I know you have a lot of experience. You've got a beautiful paper also published in the JCRS now recently. Maipal is there?
So can I have one question for Dr. Samresh?
Yeah.
Dr. Samresh, it was a wonderful surgery. But even after your posterior capsular excess, why did you have to go ahead and do a vitrectomy when your intact hyaloid face was?
Yeah, so that's a great question, Nishan. The vitreous face wasn't intact. So when I stained it with triamcinolone, I could see vitreous strands. And that's why I went ahead and cleared up that zone. Also, if you do posterior capsular excess and if there's any disturbance, it's best to go under the capsular excess margin 360 degrees and clear it. So you have a stable scaffold and your IOL won't tilt with incomplete vitrectomy that way. So it's a good idea.
Beautiful message, I think, because please don't underestimate the vitreous. And what I'm trying to say is, if you do a posterior capsular, you always check with the triamcinolone acetate, diluted triamcinolone acetate, and check whether the vitreous is there. Sometimes the vitreous can be coming, and post-operatively it will come and start peaking the pupil as well. Maipal, quickly.
So Mohan, what you said, the case that you presented, or you said if you have a mature cataract, I did have it once, and the patient, unfortunately, I didn't look at the other eye that well. Yes. And I did a capsular excess, did a reasonably good hydrodissection, and that was the fastest cataract extraction that I had. So, the problem is that the patients don't tell you that they had a problem in the other eye, and then after that they would tell me that this was earlier in my practice before Dr. Dinesh Talwar and Lalit Verma had joined, so I had to send the patient to Cyrus Shroff. So this was way back in, I would say, 98 or something like that. At that particular time, we didn't know too much about polar cataract, but then the patient never tells you that they have had a problem in the other eye. So that is something very, very important, that you have to look at the other eye. Yeah.
Unfortunately, whatever we have also described is on the femto, on the OCT. But if you have a mature cataract, as you were saying, the OCT will not be able to give you the posterior aspect of the lens. So that is a big problem. Ultrasound may or may not be able to pick up. I think it's not as reliable at all to be even a UBM to pick up pre-existing defects to that extent. So that is a absolute case where you really can't do anything, and most probably you will not be treating it as a polar cataract until, of course, the patient is giving you a reasonable history. But pre-operative evaluation, as Samresh said, even on the slit lamp, if it is not a mature cataract, you can see it. You can do a pre-operative OCT, even the IOL Master 700 at times you can do, and all these methodologies can be used pre-operatively, and the femto gives you a fantastic thing where you can have a cushion right till the end. You have pre-sectioned it, you have a good capsular access, and you can get away with I have not, touchwood, had a nucleus drop ever since I have been switching over to a femto in a posterior polar cataract, and that is a treatment of choice for me. If a patient is having a posterior polar cataract, I am suspecting a pre-existing, I will force the patient to go in for a femto. I've even done it free of cost for 2 of my patients who could not afford a femto, but I think that is a treatment of choice. I think RP Center has also published, and you can, visualization gives you a great insight. The OCT visualization gives you a great insight into what is likely to happen in this particular case.
Absolutely. I think, Maipal, you hit the nail on the head, because femto makes it much easier. You have better control of the situation, and the nucleus is already pre-cut. Everything is done. You need to just go in and do remove the nucleus. And Namrata, quickly, one or two words.
I would just like to say, one or two things. One is, if you do a swept source OCT and we have a KCR2 with us, then it picks up better than normal high definition OCT because of the resolution, which is better. UBM can pick up some of the times, like Samresh said, and we do intraop OCT. With the advantage with the intraop OCT is that as you do debulking of the nucleus and as you do debulking of the cataract, your bulk which is left becomes lesser and lesser. The plate becomes thinner and thinner, and then the visualization on the intraop OCT becomes better because now you have less amount of tissue which is at the PC. And our paper, which is on the various OCT aspects, we've described 2 signs which are very important. One is the conical sign and other is the moth-eaten appearance. So that will be published in next month's JCRS on the KCR2, and then we've correlated KCR2 pre-op ASOCT with the intra-op OCT. So that kind of really helps if you can actually correlate the two much better. And what we do now is, of course, the most expensive thing, and that is we do femto, then get the patient to an intra-op OCT microscope, and then do a IOCT guided posterior polar cataract. So it is combining all the technologies together.
Yeah, I've seen those videos, Namrata. It is very impressive. And Gaurav?
Yes, sir. I think all great points. Just 2 things to add. One is that assume that all mature cataracts are posterior polars unless proven otherwise. So that way, you can avoid hydrodissection, because mature cataracts as it is, you don't need to hydrodissect. They will rotate anyway. Second thing, if a patient has a history of previous vitrectomy or injections, be very, very careful, because you may have PC defects there. And again, these are the 2. Otherwise, Samresh, spoke so well on low infusion and control of parameters, and Dr. Maipal on femto. Yes. Both my favorite things, yes.
Yeah, Kamal?
I think, Samresh, a phenomenal video, very lucid explanation. I agree with Gaurav and Dr. Maipal. Last webinar, Dr. Mohan was with me. I showed a similar case, mature cataract with polar. You remember?
Yes.
And there also the patient history gave me away. Dr. Maipal, the patient said that Purana operation mein thoda problem tha. So we dilated and saw that the IOL was in the sulcus and there was a PC red. And this patient had come with a polar cataract. So last webinar, I showed that video. So I operated a mature cataract with a pre-existing opening, knowing that yes, there is something wrong, because the other eye, Samresh, beautiful point, that the other eye was examined carefully.
One good point is ask the patient how much time it took for the other eye. Okay, yeah. They normally come out with this thing, it will take 1 hour, 2 hours, something like that. That will give an indication that some problem has occurred during the surgery. So since we don't have any other questions from the audience link?
No, boss. There's something wrong with the link.
I just want to say one thing.
When is dinner time?
Yeah, Kumar, quickly.
Samresh, excellent talk. I just want to say that wherever we've noticed pre-existing rent in the PC, it's quite a strong hold on to that area. So it's not a weak point, it's a strong point. So all the precautions that is taken are brilliant. We have to follow them. It's not that. But I've seen that the pre-existing rents which are there in the PC are not those thin, fragile PCs. In these cases, we find them to be quite strong and they hold on quite well, is what I have noticed.
And the vitreous phase is most often intact.
No, what I'm surprised, Samresh, is that the only thing I would think in a typical pre-existing posterior polar cataract, it is not like the defect what you showed. It is like two pillars there.
Yeah.
On the posterior capsule.
Like the video I showed.
Yes, similar to what Kamal showed in the last webinar. So it's very difficult to do a posterior capsular rhexis. What I do is normally put a multi-piece lens in the sulcus and capture they do the optic capture. So this doesn't look like, it looked like for me, it looked like a Avastin, intravitreal Avastin injection, which has been given that can touch the posterior capsule. Or during vitrectomy, we have lens touch. You can have a PC flare like that.
That could very well be the case because this was only one eye cataract. The other was absolutely clear.
That is why I was thinking whether it could be a posterior polar or something else.
I think it's a very clever observation, Dr. Mohan. Whenever you have a pre-existing opening, it's a two straight pillars running from one equator to another.
Absolutely, absolutely. Very. And George, you haven't
stay in the center.
George Beko.
I have nothing to add. The comments have been really good.
Fantastic. So we'll go on to the next presenter. And again, another guy who doesn't require any introduction at all. And he is a new sensation, I would say, just like the corona. The corona is a bad corona, but this guy is a good corona. This guy is a good corona for all of us. And Ashwin Agarwal is, the next two speakers, anything can go wrong in your life. Your profession can go wrong. Your spouse can go wrong. And your life, business can go wrong, but genes cannot go wrong. And Ashwin Agarwal and Nishant have proved that very well. And Ashwin Agarwal, as you know, is a very, very good surgeon, excellent speaker, cataract, cornea, refractive, anterior segment reconstruction. He does everything. Chairman of the clinical board, and his grand rounds of the Agarwal Hospital is something which is very, very popular. And Dr. Agarwal's group of eye hospital is also the executive medical director. And over to Dr. Ashwin. Ashwin?
Yes, sir. Thank you so much for the kind words, Mohan. And I think this whole webinar has been absolutely just stunning. I mean, in its own way, in terms of what it's bringing to the audience. What I'm going to talk about today is a little different from what I think we've all seen the preclude. Actually, a lot of people spoke about it in terms of progressive conditions and having the bag IOL complex, maybe with or without a CTR on the retina, and so many problems that do come up with it. But at the same time, I think we're also speaking to anterior segment surgeons, and anterior segment surgeons having this issue of having infusion, vitrectomy, whether to do, what to do in these scenarios, especially if it's a milder case. And in these progressive conditions, milder case, what should I do? How do I precaution myself in terms of moving forward? So I'm just going to show a very simple case, but I think it's interesting. Let's watch. It's so how many times we all get this a lot of times in our cases. Can you see the video? Where I'm shaking the lens, but nothing is happening on that front. And in fact, it was not moving. The subluxation was not shown. But as and when we go into the case and we'll see this as we move, the bag is slightly moving now. If you see here, the bag is slightly moving, but that's probably not enough right now to go ahead and do anything. I know I can probably survive with the current zonules there are. And the position that we really want to hold over here is that caution, but move slowly and cautiously. One thing that what I like to do in these cases is wherever I see that maximum amount of subluxation, I always put a capsular hook. I try not to use the iris hooks, but if in case that's the only thing I have in certain centers, then that's the only thing I have. But capsular hook works really well. It goes up all the way up onto the equator. And then continue my case as a normal phacoemulsification, nothing different as such. Once you've pretty much removed, I try not to do this in the bag because any kind of zonular stress, I try to reduce that, especially in softer cataracts. And this trick, maybe I would say avoid it. You can always do an irrigation aspiration, which is what I kind of switched over to. And once you're done with the irrigation aspiration, reassess and then continue this step of final cortical removal. Why I'm saying that is you might really want to reassess the amount of subluxation. Sometimes what happens is suddenly the subluxation starts to look a lot more, and you'll start seeing that this whole bag is there you go, that compression from the equator side. But I left that capsular hook in place. I didn't actually remove it. What I tried to do different here was no vitrectomy, no infusion. The vitreous is not disturbed yet, so I really don't have any reason to go and disturb the vitreous. So what I'm trying to do here is glued, but not really glued. So I'm making my flaps in place, and next step is probably the most tricky one over here, where I have to make this into the sulcus space. I really can't go directly deep down. I have to make this sclerotomies directed first vertically down and then into this sulcus space is what I'm trying to get into. Now, I don't remove my second needle. I actually use like a Yamane technique, but just injecting that haptic into railroading that haptic into this needle. And once this is pretty much all the way in, I just remove it. And now, once I have that, I don't use any assistant usually in all my glues. What I try to do is place it inside, because you really have to go into the sulcus of the second side as well, the trailing haptic side. Now, once you're done with that, you can handshake that out of its in its way, and now you have a IOL in the sulcus space. You can use now once you remove this capsular hook, you'll see the amount of subluxation from that bag. But what I'm trying to get to is over here, if you can always try to use that anterior capsular rim. In this case, I was not able to do it, but in the other cases that I have, I was able to show that. I don't have a video of that, but if you can use that anterior capsular rim to come above that IOL, that really helps avoid any optic capture that you might have. So basically, I've not done any anterior vitrectomy or any of that. Let me tell you some advantages to this, but after this gluing. Now, I've just glued that and left it in place. Let's see, these are the 3-week post-op of the same patient. So pre and post, we definitely see a difference between the two. Some of the advantages that I wanted to say, you don't use infusion. I have not done a vitrectomy, so undisturbed the vitreous body is. Intact compartmentalization. The lens is in the posterior, that is IOL, is in the posterior chamber. There's no risk of IOL drop or tilt post-operatively. Any reduces any post-operative inflammation, and it's a very quick recovery to normalcy. These are some of the advantages that I have seen in these cases. That's my pearl, one case, one pearl that I wanted to share with you guys.
Phenomenal stuff, Ashwin. I think the supracapsular glued IOL is a technique I think you have published as well. And I was wondering why, because the subluxation was only 2 or 3 cohorts.
Yeah.
Am I right?
Yeah. It's a very good point. So
yeah, why you didn't use a CTR and put a lens in this in the bag?
Correct. I could have done that. And the patient was a young patient, number one, has at least 50 years more to go. And what I've kind of seen is in 10 years time, if it's a progressive condition, had some amount of this thing. So whenever it's a progressive condition, I always try to avoid doing a CTR unless that's the only thing that I can do. But in this case, it was more of an innovative technique to kind of stabilize the IOL while having the bag, not disturbing the vitreous, and able to successfully do it. If you have let's say you have a larger subluxation, the vitreous kind of gets disturbed. These are the only cases where you can actually go through with it without disturbing the vitreous. That's what I've seen. Maybe microspirophakia. These are some of the cases where you can get through without actually disturbing vitreous and placing an intraocular lens inside.
No, the reason why I asked that question was because when we started the glued IOLs about 10 or 12 years back in 2007 or 8, Amar always used to tell, okay, and even now we are practicing the same thing, that you should remove all the capsular and cortical remnants in the pupillary area, so that, and also the vitreous there, so that the vitreous doesn't come and get
correct
this thing into the glued IOL portion, into the sclerostomy site there.
Right.
So to prevent post-operative detachment or retinal breaks or something like that. So I was wondering whether it's a good idea to leave the capsule, because you do not know what's happening, whether the vitreous phase disturbed are there. Inferiorly, I could see some vitreous coming in that zonular area. I was wondering whether you checked whether vitreous was there or not.
What was coming was the bag, and so I was very clear on watching what that was. That was the bag trying to crumple. Usually when you lose the nucleus, the bag usually crumples on itself, and that's something that happens on the zonular weakness side. The vitreous in this case was not coming. In another case was there where you have a larger subluxation. In those cases, the vitreous does tend to come forward, and you have to actually move over to a proper glue dial in that case.
Absolutely. And before I go into the pattern, I think you showed one very important thing, that to hold the capsular the capsular excess margin with the capsular hook rather than an iris hook, because iris hook can tear the capsular excess margin, and you did that very well, and that's a very good take-home point. I want everybody to have a capsular hook in their armamentarium before they start doing all these complicated surgeries. Before we go on to the panelists, Maipal.
No, he's gone, I think.
Okay, Namrata, you tell me what.
I think it was a very nice technique, another modification of doing, another way of doing a, glued and not so glued IOL. And then I think you've also described in megalocorneas how you can take out the lens through the iris, and described here now that, you can take it out through the sulcus. The haptic of the 3-piece lens can also be taken out through the sulcus. But yes, if I had been there and not thought about glue dial, I would have done what Mohan is saying, and that is I would have put a CTR and then put
that
a
was my
lens.
first thought.
Yeah,
I completely. That was my first thought. Definitely.
If it's a non-progressive kind of a dialysis.
Yeah, Gaurav.
Yeah, I think Ashwin showed an amazing new technique yet again. And he did it so well because, it's not so easy to get, in a bag which is not totally subluxated or dislocated. Getting into the sulcus with a needle without puncturing the bag is not going to be easy. You need to really distend the bag with viscoelastic. Otherwise, there's a chance that, it'll just shallow and the needle might just catch the bag and you might get a, uncontrolled PC break. Yet, I think, this technique may hold a lot of promise in the future. It has, he showed it very elegantly. Yet again, in lesser hands, I think we would just put the CTR and put the IOL in the bag.
Kamal, thanks,
Gaurav. Yeah, I agree with Gaurav 100%. I think in Ashwin's hand, it works great. For a beginner surgeon, especially in a partial subluxation, it's not an easy task to get the needle in through and without puncturing the capsule. So he got away with it. CTR recommended for a smaller subluxation for most of the people. Yes, but again, it's an amazing technique. Yes.
So I completely agree with the whole panel and everybody here that, if you're not experienced at glued IOL, you must not try this. First, get the basics of glued IOL right. Get the infusion right, get the flaps right, get the sclerotomies right, get to do an anterior vitrectomy right. And then if you are evolved to move to this probable segment, then you should probably try. This is probably a little more challenging than normal in terms of, I completely agree, especially the 2 steps. The first step is the sulcus sclerotomy. That is the first tricky step. And the second step is to actually externalize the haptics through that sulcus sclerotomy.
Yeah.
Everything else is pretty much the same. There's nothing that changes. These 2 steps, if we get right in this, you've nailed it.
Okay.
I want to say one point.
Yeah, Kumar.
Samresh has done some research on this, because you're saying that you're putting a 3-piece in the sulcus. So pigment dispersion running off, the back surface of the iris against the 3-piece IOL is going to be much higher in such cases than you would do putting a glued IOL a little posteriorly. So I don't know if Samresh is still around, because they've done a retrospective study on where exactly to put the port and exactly where the irritation of the haptic to the back surface of the iris would be quite high in such cases. So I'm just wondering whether that's right.
Samresh videos with the Miyake views and all that is very good. Yeah, we've seen that video. That is exactly the question I wanted to ask Ashwin as well, because because it's rubbing on the back of the iris, and these are all square edge lenses.
Yeah.
And rub on the back of the iris because it's so anterior. It's close to the surface of the back surface of the iris. Wondering whether a UGH syndrome and all these problems can occur.
So what I would say is we've got about 10 plus cases of these right now. maybe a little bit more, but I think we are still on follow-up mode. It's only been a year that we have got our longest follow-up on this. I think we'll wait for some more time before I can disclose whatever the result is of that.
Ashwin, I just have one final question to ask.
Sure.
Do you feel there is some benefit in retaining the capsule? Is
Yes.
there any benefit? Because anyway, you've done a glued IOL. So what is the benefit of retaining the capsule?
As I told you, if you're an anterior segment surgeon and you're not comfortable doing infusion, not comfortable doing anterior vitrectomy, then there is some help in doing such a procedure. Number one, the anterior rim of the anterior capsule, that has vital importance even in a normal glued IOL. So I would not actually recommend anybody to remove the whole capsular bag. You remove the posterior capsule, absolutely fine. As much as possible, I try to always retain that anterior capsular rim. That anterior capsular rim avoids me from doing any single pass fourth row, so that my optic capture does not happen. That the optic capture is not, it will not happen if I have an anterior capsular rim. That IOL optic will not be able to go above the anterior rim of the capsular axis. That is a big advantage of actually holding on. As much as possible, take off the cortex, take off the bag from the posterior capsule, take off everything else, anterior zonules and anterior capsule, leave it as much as you can.
George wants to add something on, I think.
Yeah, you mean to say you want to retain, leave that anterior capsular margin on the surface of the IOL.
Yes, yes, because that then the reason I'm doing pupilloplasty is so that my optic edge does not go above the iris.
Dr. Mohan, he makes a lot of sense what he's saying. He's absolutely right, because that anterior capsular rim and the IOL behind the anterior capsular rim protects that IOL from coming up or, kind of catching the pupil. I think what he's saying is so right. Yes.
Beautiful. Very nice. I think it's very innovative. And
but there's a problem, Ashwin, because there can be some amount of capsular contracture which can happen, and then that can pull the lens this way or that way. So it's actually, I wouldn't really recommend that from my point of view. The other thing is, when you're trying
bag
to,
is not there. How can
no bag, but still there is some. It's going to be, if it's going to be close to the capsule. The other thing is, when you're trying to exteriorize the haptic, if there is a capsule, that can actually make it more difficult. So that is one point I have against leaving behind a capsule.
Leaving behind the posterior capsule or the anterior, ma'am?
You left behind the whole bag, isn't it?
In this case,
okay.
In this case, I agree with you that leaving behind the bag. But as I said, I think the bag contracture will happen only if there's something inside the bag. One. Second is what is happening in this case particularly is I had a clean bag. I had a very small amount of subluxation. And the most important over here was I did not want to disturb the vitreous, which was not disturbed. So keeping these things in mind, and it gives another armamentarium to some direction where you can actually do a glued where you have stable IOL while not disturbing the whole vitreous or posterior segment.
The technique was excellent, that I must say. It's very good technique.
George, you would like to comment on that? Have you tried this?
I kind of agree with Sujatha. I'm not sure what the benefit is of saving the bag. And in this particular case, with only a few clock hours of loss, I'd be tempted to put a multi-piece IOL, put the haptics in the direction of the loss of the zonules, and put in a CTR. If I had more loss and I had a preserved anterior capsule with a capsulorhexis, I would put my haptics into the sulcus and just optic capture with the capsulorhexis, the optic. David Chang's been doing that for over 10 years and shown that works quite well. So I have to, and again, Ashwin, you did a fantastic job, but I have to wonder why we need to glue that IOL, because we haven't seen that those will dislocate, especially with the amount of loss that you have there.
Sure, I agree with all your comments, George. I think
it's a beautiful. I think
but I think your comments about being careful about how you orient the the needle are very important. I mean, if you saw my first case where I put the piggyback into the sulcus and had to glue it, I came almost at, parallel to the iris in the way that I penetrated the eye. And then you have to be very careful about what you're doing.
Absolutely. I think it's
orienting towards the center of the globe, it's actually doing it at a different plane. And so I think that's the important part from your video, showing how to orient that needle.
I think one is two important things are there. One is the distance from the limbus and the direction of the needle. Am I right, Ashwin?
Yes, sir. Absolutely.
Yeah, absolutely. So we go on to the final presentation. Always we keep the best for the last, and Mahendra Singh Dhoni is always a finisher, and Nishant is the finisher for us. And Nishant and Nivian have taken MNI Hospital to totally different level altogether. They are also a postgraduate institute. Nishant is a very young guy, and he's a good cataract and cornea and refractive surgeon, and from Chennai. Over to Dr. Nishant, and it's always a pleasure to have Nishant here with us. And
thank you.
Nishant, all yours.
Yes, sir. Thank you, IIRSI, Amar sir, Mohan Rajan sir, and the whole panelists. I'm just sharing my screen. Is it visible, sir?
Yes, sir.
Yeah. So a very good evening to esteemed ophthalmologists, or rather I would say a very late evening to everyone over here. So I'm sure that all of us must have seen this movie Armageddon, where the amount of stress and the skill they take to implant the bomb in the center so that the nucleus breaks completely into two halves is what I'm going to talk about. So I'm going to give pearls on how do we crack a hard mature cataract. Dr. Samresh has told about the PPC, and I'll talk about the hard mature cataract. I have no financial or political interest. I'll say in the end why I said this actually. So we all come across cataracts like this, which are actually very hard, and we start trenching for a long time. We do a lot of trench. It does not trench too much. Even if we use high phaco energy, there might be an endothelial loss or wound burn. And even if we try to crack these nucleus, I mean, there are two fast phaco surgeons in Tamil Nadu. One is Nishant and one is Dr. Mohan Rajan. Mohan Rajan shoots the nucleus anteriorly, but I think you all see how Nishant removes this nucleus in a fraction of a second. But the only thing is it goes posteriorly. So how to avoid these kinds of situations are the tips which I'm going to give. To start basic, I would say about the side port. If you can see the side port which I make on the right side will always be the full thickness. And the one which I make on the left side for only the dialer or the chopper, you can see that I go only half the distance so you don't have wound leak. And I don't use an air bubble through the right side because you can see that the air bubble keeps coming out. So what I usually do is go through this side, form the air bubble so that while staining, the corneal endothelium does not get stained. And while washing it, do not use the left side, use the right side because you want the saline to come out. So these are few tips which I would say for staining the nucleus. And then for making the clear corneal entry, I always make a small first incision groove. The second, I do a small tunnel with my keratome. So this makes that the second plane is absolutely stable, and then it's almost like a triplanar incision which you are doing for even a clear corneal phaco. So the wound integrity is going to be amazing, and the chances of wound burn are going to be less. So this is one of the technique which I'm going to show for the mature cataracts for beginners to convert, because they are the ones who are always afraid about the hard mature cataracts. So I make a groove, but the only thing is I don't make a full groove, but I go to the end of the groove and bury my phaco probe. So you can see that the cracking is done very easily, and it does not need too much of phaco energy where you have to do something like a 4-quadrant, and you need not be worried about a direct chop which you have to bury too much into the nucleus. You can see that once you get it into two halves, I'm definitely sure that it's going to be like any other phaco surgery. So this is what I'm going to talk about. So I got this technique called the V chop. So you should see that I'm making a small V from the entry on both sides. So this requires very less phaco energy, and exactly at the apex of the V, I start burying my phaco probe. The only way to know that the phaco probe is deep enough is your phaco probe should not be seen from anterior. As you can see, it has disappeared. Then I go from horizontal and split it vertical, and you can see how neatly it is chopped. So this need not have too much of pressure. And for surgeons who are just converting from a stop and chop to a direct chop, you need not fear that whether you are buried enough into the nucleus. Because the only thing about a chop is make sure that your phaco probe is buried always into the nucleus. If it is too anterior, you will have a slip of the phaco probe. And once you get all the cataracts, which is made into small pieces, emulsification is going to be very easy even for a mature cataract. And one more small thing is keep the phaco probe always in the center at the level of iris plane, not too close to the cornea to make sure that the endothelial loss will be there, and not too down to the posterior capsule because the chances of the posterior capsule rupture will also be there. You can even try to make use of the burst mode. Make sure that you know your parameters for your burst mode and make sure that the anterior chamber is always perfectly formed in these cases. You can see that even after a hard mature cataract, this kind of clear cornea is, and without any wound burn, is all what we expect out of mature cataracts. So this is the technique which I told you to start with. If you're finding difficult to do the V, you can actually do it one side like a small groove near the capsule margin, rotate the nucleus, and then you do the other V there if you're not able to get the V from the tip. So then you can see that I've buried, and then the chop starts. Like Dr. Gaurav sir said that the chop depends upon what your comfortable is. Dr. Nivian, my brother, he always said that it's neither the direct chop, nor the vertical chop, nor the horizontal chop. It is your chop, which is the best kind of a chop. So you should know which chop to use for what nucleus. These are leathery cataracts, and even for these, it will be the best. And we all know the magic wand of Harry Potter, who says the expectro patronum for defeating all the devils. So the same way the phaco probe is in your hand to make sure that all these kinds of cataracts get these kinds of amazing results with the V-chop. As I told you in the beginning, there are no political interest. So what I meant V was for victory. Keep that in mind. And I thank Mohan Rajan sir and all the speakers and the panelists. Thank you.
Beautiful. What a lovely presentation, Nishant. I think at the end of the day, I think you've got some very nice messages. Only thing is, in the mature cataract, when you want to do the V, because you are in the periphery, not in the center, when you're making the groove, what will be the size of your rexes there?
For mature cataracts, I make it around 5.5 to 6 millimeters.
5.5 to 6 millimeter.
Yes.
Because if you're going to be a little larger rexes, it's going to go to the periphery in mature cataract. More chances of going to the periphery. I want to take the opinion of Dr. Namrata, Gaurav, and Kamal quickly on this. Namrata, what exactly is your take on this beautiful
I think it was a beautiful video, Nishant, and so many things you take for granted, but those things you spelled out in your video, and that was the best part. I mean, you just think you would do it like that, but you made it's a great teaching video for the fellows, and your V technique is also very impressive. In hard cataracts, whenever you try to put the phaco probe, that tongue thing, you know, the tongue sort of a protrusion always comes out, and then that tells you that it is going to be hard. So you've taken advantage of that very fact, and you have extrapolated it into, you know. So I think it was a great demonstration, and Dr. Mohan Rajan pointed out very rightly that you should not be taking it to the periphery. It should remain in the center and should not be making a very large rexes also. So I think he covered almost
beautiful.
everything.
I think beautiful.
Nice. Yeah.
Very nice message. Some people do the horizontal trench instead of the vertical. In hard cataracts, they make the horizontal trench and then go bury into the this thing. I find, Nishant, before we go to the Gaurav and thing, I find that your tip is not sufficiently exposed. When you have hard cataracts, I always make sure that your tip is very well exposed. Yeah. Kamal and Gaurav?
Yeah. I think a wonderful video as usual, Nishant, you know, very crisp understanding of the dynamics and the phaco and the settings of the machine. I find your explanations are very, very lucid and very in-depth. Few things, as Dr. Mohan said, whenever I'm doing a hard cataract, I do a few things. People may frown at that. I make a slightly leaky wound for the reason I will not land up with a burn. So just before I'm about to come out with my keratome, I just move my keratome slightly one way, and probably from if I'm going a 2.2, I may be making a 2.3 or 2.4. So I never get a wound burn. If I can use a lot of phaco energy and still get away with it because my sides of the wound are pouring out water, number one. Number two, I expose the phaco tip higher than normal, as Dr. Mohan Rajan said. Number three, I do not, in these cases, the zonules are a bit goner. They're a little weak. Anterior zonules are weak, especially in the advanced cataracts. And you will need a lot of chopping energy, give a vertical pressure downwards. So what I do is, if I'm not able to make a deep trench, I do not go for it. If it's a cataract is very hard, I'm not able to go deeper, then I go to create a burrow. So what I do is I embed my phaco tip into a burrow and I lift the whole nucleus up while my chopper is going down. So the forces on the bag are distributed. And then as I'm approaching my phaco tip, I separate. So this is the second thing I do. The fourth thing I do is I aim for a larger rhexis. A 5.5 would be a normal size rhexis for me. But in case I'm going in for a harder cataract, a crisp brown or a beetle nut cataract, I would aim for a larger rhexis because, that will give me a lot of freedom to move around into the bag, move with my chopper, do a side chop, vertical chop, peripheral chop, flip chop. So going in for a larger capsule rhexis makes a lot of sense. So these four little points I would be handling slightly differently.
Also, Kamal, when you have a larger rhexis, the chances of damage to the bag becomes much less. So the chances of zonal dialysis is much less. So you have.
That's what I said. 5.5 is not.
Brown cataract about 5.5. I make
bigger than 5.5. Sir. I would say 6 millimeter is a good size.
No. In the mature cataract, it's not a good idea to go larger because you can lose.
But I think we have to differentiate between an intumescent and a hard cataract. If it's an intumescent cataract,
when we say a mature cataract, it necessarily may not be an intumescent cataract.
Hard cataracts.
Right. But if you have a hard brown cataract with almost negligible cortex and no intralenticule pressure is not high, I would definitely aim for a bigger rhexis like the 5.56 as Kamal said, because that gives you ample room. Because when you're doing lateral separation and you're chopping these nuclei, you tend to break the rhexis sometimes. So having a bigger rhexis is always going to be good. Second thing, I think everybody's given all the points. I'll just add one or two which I think might add on to this. When you're doing lateral separation, as you have to do in hard cataracts and they are leathery, you have to go to the posterior extent and do the lateral separation. If you try to do it anterior, you'll have to stretch the rhexis much more. So I think that's one additional point that, be very careful about the lateral separation. Go down deep into the trench and then separate from the posterior plate rather than, trying to separate the anterior plate and expecting it to extend to the posterior plate. That's one thing. Second thing, I feel that the woodpecker technique works really well in my hands for these supra hard cataracts. And you can, embed and then put in your chopper, try to, bring it closer and then give a burst of phaco, that immediately translates into a chop. And I think it's worth trying. I've used it all these years. And the third thing that I might want to add here is that for the supra hard cataracts, if it's like a black cataracta nigra, I will not hesitate to shift from a direct chop to a stop and chop at any time. I think for all people who, are not 200%. The best, like who don't have the Mohan Rajan chopper with them, for them, we have to, think about doing a stop and chop. It always helps, but you don't have to have a very large trench. If it's just 1 to 1.5 times the width of the, this thing, and then only the central part is where you really need the trench to go deep. In the periphery, you don't need to go very deep. So these few tips, in addition to what everybody's already added, I think the talk was excellent.
Beautiful. I think it's a beautiful talk, and you given all the messages, Gaurav, Kamal, and Namrata. All the panelists, and it's a beautiful.
George wants to add something, Mohan.
Yeah.
He's shaking his hand. Yes.
Who's that?
George.
George. Yeah, George. Yes. George and
George has gone into a shadow in front of the Niagara Falls. The picture is so beautiful. George is not visible to us as much as the Niagara Falls are.
Yeah. George. Yeah.
We can't hear you, George. You have to unmute yourself.
You're muted.
There we go. So as we see here, we're split between the people who want a big capsule rhexis and the people who want smaller capsule rhexis. And I think you can argue one way or the other. The points that I would make is I use bevel down on the needle. I noticed your needle was bevel up. When it's bevel up and you're putting all this energy,
I also use bevel down. Yes,
the endothelium. So I put bevel down. The other thing is I'd love the ultra chopper when we had it. We don't have the ultra chopper anymore because that would be very good for these cases. But what we do have now is the MyLoop, and I've used that on a number of these cases, and it's very helpful. So if you have access to those devices, they make these cases much easier.
Yeah, I think for the black cataracts, I have the 2 millimeter chopper. All of these are made by Appaswamy. For the brown cataracts, I have 1.75. It's long and sharp. Only thing is you need to go bevel down, vertically down. Okay, these cataracts are very, very thick cataracts, about 5-6 millimeter or more than that. And you have to go bevel down. And quickly we'll wind up with the session because we're running short of time. Kumar, you would want to say something?
Excellent, Nishant. As usual, the talk was very good. Again, I'm in the group where I would prefer a 5.5 millimeter rexis because worst case scenario, your nucleus goes in. You can still put your lens in the sulcus and then your retina team can take over and the rest can happen. So my thought would be like that. And the sharp tip chopper, as Mohan said, I've been using that for years. Works beautifully well in such cases. As far as wound burn is concerned, I've not seen a wound burn since 2001. Maybe because of newer technology that we're using, cold phaco that we're using, I've not seen a wound burn at all. So that's a benefit that we get with the newer technology with cold phaco that I don't think we see anymore.
You know, the wound burn, you know, when it occurs, we be careful when you use, because we use a lot of viscoat. When you go inside, please aspirate the viscoat before you give
Absolutely.
the power.
Yeah,
that is one of the most important
very
good
tip.
and it can be very bad. It can be very bad. It can screw up the entire case.
Yes,
and
absolutely.
Please
and one point is that you see, not everybody not all of the viewers are probably having access to the technology what we people are using.
True.
Kumar sir, the only thing about the VR backup was, my VR backup is Dr. Nivian. So he has told one thing: if you drop a black cataract, he said actually don't place a lens because he said it is easier to lift it out, make a small incision.
Absolutely, because fragmentome mode doesn't work much. This thing work for the brown, very brown or black cataract.
But at the same time, if you have a 5.5 millimeter rexis, you can do a sulcus fixation with an optic capture in the same rexis. So that's an additional benefit. So I guess you don't put a lens, but it's an easier thing to do.
Yeah.
But Kumar, you'll have to sacrifice the rexis if you're floating out a black cataract anyway.
Absolutely, you will have to. You can't get a 12 millimeter.
Go for glued IOL.
You can't get a 12 millimeter nucleus out of 5 millimeter.
When you have a black cataract going inside, you have to sacrifice everything. That is the take-home message. One
Dr.
case.
Mohan, I don't know if you have any viewers.
You can't hit the nail on the head. And so I think we have come to the end of the session.
Dr. Mohan, you have set one more record now. After 50 OPLs, you have set one more record
This
of the
is
longest
webinar ever.
Longest webinar ever. Huh?
No, I think it's well received. I've been getting a lot of reviews about this, raving reviews about this webinar. I'm sure
we had huge viewership. Yeah.
I would like to thank all the panelists, but before that, I request my co-moderator, Dr. Ravi Shankar, is online there.
Yes, sir.
Dr. Ravi?
Unmute, sir. Ravi, sir.
Yeah. Ravi Shankar, please. Can you just give the vote of thanks? Yeah.
It was fantastic and it was a marathon webinar. Very happy to see Dr. George Baiko sitting there from even 6 o'clock.
I know.
In fact, everybody joined after 6:30.
I
but
know.
he's been
Dr.
there
Baiko
since
was
6
there
o'clock.
before
Thank
me.
you, Dr. George. It was fantastic to have you on board. And great cross-learning and a lot of take-home messages. All the presenters were excellent. They were up to the mark, and every case definitely had, it was a single case, but there were a lot of pearls to take home. Thanks a lot, and it's a pleasure for us from IIRSI to thank each and everyone who have participated in this webinar, and particularly the panelists. You've been wonderful. You took off your Saturday evening and you were here, the long 3-hour, almost more than 3-hour session, and I thank each and every one of the panelists who made it wonderful this evening. I need to thank all the speakers. Everyone had wonderful cases to present and really superb. There was, as I already said, there was a lot of cross-learning and a lot of take-home messages. Thank you once again, all the speakers. I would be failing in my duties if I do not thank the medical support of this meeting done by Entod International. Thank you, Team Entod, for being so kind enough for supporting this meeting, and we'll be looking forward for many more meetings in future. And thanks to Dr. Kamal once again for making this bang on to the international viewers. As usual, thanks, Dr. Kamal, and a big thanks to each and every one of you. If I have not named anybody, if I have not mentioned anybody, it's just I would have forgotten. That's all. Thank you so much and good night to you.
And I would like to thank duty if you don't thank Amar. Amar is the main person who's as you all know, is the colossus of ophthalmology for all of us. And he has given this wonderful opportunity to all of us to do this webinar under the banner of IIRSI. And we have got one case, many pearls, but ultimately take-home message is we have got 14 gems here. The 4 panelists and the 10 speakers. The 14 gems, the gems of India and gems of the world. Thank you very much. Good night. Stay safe.
Thank you.
Thank you.
Bye-bye.